Next kada next Okay, good morning everybody, and let's start the meeting. First of all, on behalf of the IBD AIG team, I'd like to welcome you all to this very small expert meeting. Before I start, I'd like to thank Takeda for the educational grants and Abbott for the silver sponsorship. This meeting was initially started as an expert consensus meeting with two purposes. I'll come to that, but before that, it was also last week we decided to open it up for people to register across on virtually also. And surprisingly, we have 2,000 registrations virtually from 35 countries. So all of them also. We have a huge audience also, not just us, but watching this. Most of them are from ENC. All these 35 countries are from emerging nations, because later on they'll also participate in the consensus. So the main purpose of this meet actually was first is to review advances in this area, because endoscopy and IBD sometimes not discussed totally in each forum. The endoscopy forum is not discussed, and IBD forum is not discussed. So we thought in recent years there's been a lot of advances in both diagnostic and therapeutic endoscopy and IBD. For example, there's a lot of articles coming on image-enhanced endoscopy versus chroma endoscopy. The situation in our country, of course, is different, because not many people would still do chroma endoscopy. Several scoring systems are coming in, and inter-observer variations are changing with that. In fact, we recently had a paper on artificial intelligence, how to get these inter-observer variations into scoring systems, because you have UCIS, you have Mayo subscore, all sort of confusion coming in this area. And of course, I think one of the most important revolutionary things in endoscopy that happened in this area is the motorized spiral enteroscopy. And having watched its progress in the last 1 year, I think we should start giving up doing other forms of enteroscopy in these patients, especially if they can afford it. Motorized spiral is the way to go, because pan enteroscopy is now possible in 95% of the cases. I think Partha will tell you about that a little later. So these advances would mean that we should have an ability to look at literature very thoroughly recently. And of course, therapeutic endoscopy also has progressed. We have several talks on this, and we'll have an overall talk from US also summarizing what is happening in this area. The ability to recognize the dysplastic regions and the ability to do bigger ESDs, CMRs, and also I think structuroplasties and all have added another dimension. So I think this whole field is moving very rapidly, and so we thought it was the time to get used to this area and then get the latest among people who are working it. So second purpose of this meet is that it was also thought that we should be initially we thought guidelines, but we decided it can't be a guidelines meet, because that's more rigorous. It will take probably a couple of days to do guidelines in this area. There are several guidelines already available in endoscopy, the ECHO, STRIDE, and of course the CINIC guidelines. But what we thought is that we'll have our own consensus based upon the emerging nations consortium. So the process for this would be that after the talks are over, we have statements that have been made, and already Partha, Vishal, and Raj have worked on this to give it some evidence based on the Oxford system. So we are going to, each statement is going to be modified after the talk by the expert panel here. I think they are already started, they've each got some statements to modify. Once these statements are modified, then we use the Delphi system. These are going to be sent to the leading members of the ENC group, who would then look at it, and the voting would be done, and more than 80% will be taken as accepted for a statement. The more rigorous grade system would take a couple of days, so we thought we'd follow this system, which would be quick and give us a broad consensus, because we are not looking at guidelines, we're looking at a consensus of what we should do in the emerging nation. I'd also take this opportunity to welcome all the emerging nation leaders who are actually virtually now on the Zoom watching this program. I think their inputs later on would be extremely useful. We couldn't get them live to put inputs because again it takes a lot of time, confusion comes, so it will be live would be only with us. they are actually watching, and later on they'll get all this sent to them so that voting can be done. So I think we look forward to a very exciting day of getting updated on this and probably forming a real consensus on this area. Now I request Dr. Rupa to take over and start the proceedings. There's a timer here. The timing is going to be very strict. Timer here, 10 minutes, each talk on the laptop, and a buzz will come from Satya at the end of 10 minutes.
So I think a warm welcome for a hectic day ahead. We intend to finish on time. That's the first thing. It's primarily going to be small talks followed by longer time for discussion. And the discussion will be moderated by one of us. So the first session is endoscopy in IBD, indications, timing, scoring, special situations. And to give the first talk, I'd invite Dr. Vishal Sharma from PGI Chandigarh, indications and timing for endoscopy.
Thank you, sir and madam, for the kind invitation. So over the next 10 minutes, I'll try to cover the major indications and the timing for endoscopy in inflammatory bowel disease. And these, whatever I'm going to speak, is largely based upon various guidelines which are already available. So ileocolonoscopy is the diagnostic procedure of choice for suspected IBD. And when should one perform? As early as possible when IBD is suspected, before initiation of any IBD-directed therapy. And in some of the patients where colonoscopy may not be done immediately, like acute severe, one would do an early sigmoidoscopy and follow up with a colonoscopy within the next 1 year. Now, what about the role of upper GI endoscopy in patients with IBD? So it is not routinely recommended for asymptomatic adults. However, it is routinely suggested in patients with pediatric and adolescent IBD, and there are some studies which suggest that there is an additional diagnostic yield for doing an upper GI endoscopy. Symptomatic adults who have vomiting, abdominal pain, or dyspepsia may be considered for a upper GI endoscopy. Now coming to capsule endoscopy, in suspected Crohn's disease and a negative ileocolonoscopy and equivocal imaging, one could go ahead with a capsule endoscopy. Minor changes on capsule endoscopy, especially in setting of NSAID use, are not sufficient to diagnose Crohn's disease. And if there are obstructive symptoms, it is reasonable to do a patency capsule prior to going for a capsule endoscopy. Now, what is the importance of the first endoscopy? It is most helpful in discriminating ulcerative colitis and Crohn's disease. And the reason is that on follow-up, therapy can vitiate the findings. So if there are local therapies being used, rectal sparing can be seen. And again, there could be skip lesions or segmental involvement because of various drug therapies. Now, there are certain red herrings which one should be aware of. Rectal sparing is especially common in pediatric and adolescent ulcerative colitis, and so is segmental involvement. And therefore, that should not be used as an evidence in favor of Crohn's disease. Now, backwash ileitis can occur in around 20% of patients with a pancolitis, and appendiceal patch is not equivalent to skip involvement. So it is important to distinguish backwash ileitis and Crohn's disease. So usually, backwash ileitis will be a mild inflammation only for terminal few centimeters of ileum in setting of pancolitis. On the other hand, presence of discrete ulcers, strictures favor the diagnosis of Crohn's disease. Another important role is in the differential diagnosis, and especially in the first presentation, there may be a confusion with acute colitis. Now, certain infections like Shigella, Salmonella, Campylobacter can mimic ulcerative colitis. Tuberculosis and Yersinia can mimic Crohn's disease. And especially in our region, it is very important to exclude tuberculosis while making a diagnosis of Crohn's disease. And certain endoscopic findings like transverse ulcers, patulous IC valve, or a cecal IC involvement favor the diagnosis of Crohn's disease. On the other hand, longitudinal ulcers, aphthous ulcers, and a left colonic involvement may favor a diagnosis of Crohn's disease. Now, there may be some patients where a diagnosis is not achieved even after microscopic, microbiological or histopathological evaluation. And usually in this region, we start these patients on antitubercular therapy. And the question is when to do a repeat colonoscopy. So there is evidence from our own institute that repeating a colonoscopy can document ulcer healing in patients with tuberculosis after a ATT trial, and this has been confirmed by 2 other studies from China. Now, when to repeat a colonoscopy? When initial diagnosis is uncertain or the initial examination was not complete. Another important reason is that at around 8 years, now there are multiple reasons to do that. We know that the extent may change and this helps in re-evaluating the extent of the disease. Second is, of course, screening of dysplasia in E2 and E3 disease and ulcerative colitis and 1/3 of or more of colonic involvement in Crohn's disease. And of course, if there is a change in the extent, then there is a subsequent decision of screening and how frequently that screening has to be done. So this is where repeating a colonoscopy is important. Now, should we repeat a colonoscopy during remission? When there is a clear-cut remission, usually repeating a colonoscopy or an endoscopy is not recommended, but it should be done if there is a relapse or a non-response to therapy or steroid dependency. Now, again, very important is in the current era, what is the role of repeating an endoscopy for response assessment? So STRIDE 2 has given now targets to treat, and one of the target is mucosal healing or endoscopic healing. STRIDE 1 talked about the timing, and it was a blanket timing given of around 3 to 6 months of starting a therapy for ulcerative colitis or 6 to 9 months in Crohn's disease. But STRIDE 2 has tried to give some expert consensus on the timing with respect to each of the drugs. So there's a separate talk on this, so I'll not go into the details of this. But depending upon the agent which is used, the timing of a repeat endoscopy can be selected. Now coming to screening for dysplasia, so there are multiple guidelines, but I'll summarize them. The first screening endoscopy should be done at around 8 years. So that will tell if there is a change in extent, increase in extent, and further decisions are on the basis of risk stratification. So whether there is a active disease, mildly active or no active, or there are presence of pseudopolyps, colorectal cancer, strictures, dysplasia, that decides how frequently a repeat dysplasia screening is to be done. Again, patients with PSC are candidates for upfront colonoscopy and a yearly colonoscopy. And again, Crohn's colitis, that depends upon the extent of involvement. Usually more than 1/3 of involvement qualifies for a screening. Now, when to do a re-examination after resection of dysplasia? Now, that depends upon the type of lesion which has been resected. So, in patients with non-polypoidal dysplasia and large polyps or polyps which have been piecemeal removed or ESD or EMR has been done, the initial colonoscopy has to be done pretty early, and then it is yearly. Whereas small polyps which were resected en bloc, one can do an initial colonoscopy at 1 year. Now, there is a role for therapeutic endoscopy, and there are talks related to that later on, but largely this is for short CD-related strictures, which can be initially treated with a balloon dilatation, and if they are refractory, then other forms of therapies like incisional therapy or fully covered SEMS may be alternatives. Now, there is a role for in the post-operative phase also. For example, there is a role for pouchoscopy in patients who have pouch-related symptoms, and then there is a need to evaluate not just the pouch, but also the cuff and the pre-pouch ileum to diagnose whether the underlying reason is cophitis, pouchitis, or a Crohn's disease. Now, there are some guidelines which have recently been published, which talk about a pouch surveillance, and they talk about annual screening in a subset where there is IBD associated cancer, a 1 to 3 yearly screening if there is a history of PSC, a chronic inflammation in form of cophitis or pouchitis, a Crohn's disease of pouch, a long duration of ulcerative colitis, or a family history of colorectal cancer, or a type C pouch mucosa where there is severe pouchitis ongoing after surgery. Now, in individuals who do not have these risk factors, they can be taken up for a 3-yearly pouch surveillance. There may be a role for therapeutic pouchoscopy in certain situations like pouch-related strictures. Now, coming to another post-operative indication, which is recurrence of Crohn's disease. So we know that the most frequent site of recurrence is the neoterminal ileum. And the endoscopic recurrence precedes the clinical recurrence, and we want to prevent clinical and surgical recurrence. So this may be a strategy to classify the endoscopic recurrence and make changes to the prophylactic therapy or add additional therapy after doing an endoscopic surveillance. And that is usually recommended at around 6 to 12 months after the initial resective surgery. And the only randomized trial which is available to assess this strategy had done a colonoscopy at 6 months. So to summarize, ileocolonoscopy is the standard for diagnosis of inflammatory bowel disease and also to discriminate IBD from the mimics, TB, and especially tuberculosis in our setting. Till we have better or clear surrogates for endoscopic healing, endoscopic assessment is the standard for documenting endoscopic healing, and the time points vary with the therapy. Surveillance for dysplasia should be individualized based upon risk factors after the initial colonoscopy at around 8 years of the disease onset. Endoscopy has a role in therapy, especially in complications like management of visible dysplasia and treatment of CD-related strictures. And certainly it has a role in post-operative setting for diagnosis of post-operative recurrence of Crohn's disease and pouch-related problems. Thank you.
Vishal, your statements?
So,
Dr. Nijavan, would you kindly join me here moderating this session? So maybe we can have your statements right at the end, Dr. Vishal, and then we can have a consensus.
Are you projecting statements here?
The plan was that for every talk at the end there will be questions and the statements, and after the talks are over, the whole time will be used to agree on the statements and edit or any other changes.
So can I put a question?
Yes.
Vishal, excellent presentation, very well summed up. So my just a small point, sir. Now, upper GI endoscopy, you have put the indication, you have put in the same bracket for UC and Crohn's. Will you like to differentiate between the two? That's my first.
so that I think is a very important question. So I was biased by what has already been suggested in the pediatric IBD guidelines, but I agree with you that if you look closely at the evidence, the additional diagnostic yield of upper GI endoscopy is only for the diagnosis of Crohn's disease. Only problem is that sometimes it is difficult in pediatric patients to upfront say whether it is ulcerative colitis or Crohn's disease. So the blanket guideline has been given for IBD. But I agree that the diagnostic yield, additional diagnostic yield, is only for Crohn's disease.
Second question was sites of biopsy when you're doing the first colonoscopy in, say, ulcerative colitis to define the extent of the disease. Do you think we should have from the entire colon to look at the, I mean, say, endoscopically, I find the visible thing in the, say, up to sigmoid colon. But do you think extent of the disease can be clearly determined by that, or we need to do?
So I think, sir, that is the next second.
Okay, I'm so sorry. Okay. The second question, then I'll put is that you put 2 months as a TB versus IBD thing. But if you look at Govind's data, it had shown much later than that. I think it was about 6 months of 4, something like that.
So they had done only at 6 months. So that is the problem. They will not be able to say what was happening at 2 months. Because they have not done at 2 months. In fact, in a subsequent follow-up, we have also seen that the calprotectin decreases. So this means that mucosal healing is happening at 2 months.
We can have the questions at the last because there can be something being answered in the next talk. So now we invite Dr. BD. He'll be speaking on endoscopic biopsies, how many from where to be taken. BD, please.
My friends, for next few minutes, I'm going to talk about the endoscopies, biopsies, how many and from where. This is what we have got. Endoscopy plays a fundamental role in the diagnosis, management, and the treatment of inflammatory bowel disease. And also the colonoscopy, sigmoidoscopy, or upper GI endoscopy as a whole has long been used for the care of the patients with IBD. Dr. Vishal has already mentioned about it. Colonoscopy with ileoscopy allows the direct visualization as well as the biopsy of the mucosa of the rectum, colon, and the terminal ileum. The point is, there is no endoscopic feature is specific for CD or ulcerative colitis. A single reference standard for the diagnosis of Crohn's disease or ulcerative colitis does not exist as of today. The diagnosis of CD or UC is based on the combination of the clinical, biochemical, stool examination, endoscopic cross-sectional imaging, as well as the histopathological investigations. Biopsies are routinely obtained during endoscopy. It is important for the endoscopist to consider what specific questions he or she is asking to the pathologist, what he wants in fact. This is what the important things, the assessment of the crypt architecture, distortion, the non-cageating granulomas, histological changes even in the endoscopy normal areas of the colon, cytomegalovirus, search for dysplasia, or identifying the lymphocytic colitis. During the initial diagnosis, endoscopic evaluation, the specimen should be obtained from both the disease as well as the normal appearing mucosa. The normal mucosal biopsies effectively excludes the active IBD. For IBD diagnosis, multiple representative biopsies in a standard protocol are usually needed. At least 2 biopsies from the 5 sites around the colon, including rectum and the terminal ileum, if possible, should be taken. The biopsies should be representative from the minor and major inflammation to mirror correctively the intensity and the spectrum of the inflammation. In addition, the biopsies must be taken also from the normal mucosa, normal appearing mucosa. That's what it was published in different publications. For the reliable diagnosis of UC and CD, ileocolonoscopy with a minimum of the 2 biopsies from the from the inflamed region should be obtained. That's what the publications already mentioned about. The additional biopsies from the uninflamed regions and every colonic segment, including the rectum in case of UC, may be helpful for the diagnosis. When IBD is suspected, 2 biopsy specimens from 5 sites, including the ileum, rectum, are recommended. The biopsy specimens should be obtained from both affected as well as the normal appearing mucosa. The specimens from different areas should be labeled and submitted separately. This is what we have to say here. When IBD is suspected, 2 biopsy specimens from 5 sites, including the ileum and the rectum, are recommended, and this is from British Society of the Gastroenterology Consensus. Then again, the biopsy specimen should be necessary to determine the extent of the colon that is inflamed, which in turn can aid in the determining the prognosis and direct appropriate medical and surgical therapy, and to stratify the risk of the diagnosis. The American College of Gastroenterology again in 2019 put this for ulcerative colitis, that the colonoscopy with intubation of the ileum and the biopsies affected and unaffected areas should be obtained to confirm the diagnosis of UC by a trained pathologist with expertise in the GI pathology, and whenever it is a possible one. So ECO and the European Radiological Association guideline also, they have put the suspected IBD ileocolonoscopy with biopsies from inflamed and uninflamed segments are required to establish the diagnosis, except in the case of the acute severe colitis, where probably sigmoidoscopy is sufficient one. Then we have the additional issues. In adults with the unclassified IBD, upper GI endoscopy can be an aid for the diagnosis of CD, just now because mentioned about it, and otherwise it is not required. For this one again, the upper GI endoscopy is routinely performed for pediatric and adolescent IBD. But again, there is a question mark about the use of upper GI endoscopy in case of the adult population of IBD. Echo statement for a reliable diagnosis of the CD and UC, multiple biopsies from 6 segments, terminal ileum, ascending colon, transverse colon, descending colon, sigmoid colon, and a rectum should be obtained. And the multiple biopsy imply a minimum of the 2 representative samples from each segment, including the macroscopically normal segment. That's what their statement shows. Then European Society of the GI Endoscopy guidelines also suggest the performing the segmental biopsies, at least 2 biopsies each segment, which should be placed in different specimen container: ileum, cecum, ascending colon, transverse colon, descending colon, sigmoid, and rectum in patients with clinical and endoscopic signs of colitis. The same European Society of GI Endoscopy guidelines says taking 2 biopsies from right hemicolon and also from the left hemicolon separately for diagnosis. It also says that these are being taken for the diagnosis of chronic idiopathic IBD. The sample should be sent in separate designated containers. I'm finishing the next one slide. In Crohn's disease only, sometimes you may need to go for upper GI endoscopy. The statement what Rupa asked me to talk about, probably this is my suggestion. For initial diagnosis, at least 2 biopsies should be taken from 6 segments: terminal ileum, ascending, transverse, descending, sigmoid colon, and rectum, and even in the absence of the macroscopic disease. That's what my suggestion. With this, I thank all of you for your kind attention.
We'll discuss the statement in the last one. Now the third talk will be by Dr. Ajit Sood. He'll be speaking on endoscopy findings and scoring systems for routine clinical practice. Sood, please.
Thank you. I'm going to take up an endoscopy finding and scoring system for routine clinical practice. Endoscopy has a pivotal role as the diagnosis of IBD is based mainly on the endoscopy findings, and it helps in following up a case of both UC and Crohn's to see the assessment of the response. Now I'll be starting with the ulcerative colitis followed by Crohn's, and we will be starting first with the active disease. Now coming to the scores which are commonly used for active ulcerative colitis or to assess the activity of the ulcerative colitis, Mayo score is the most commonly used and all of us are very familiar. It's based on presence of erythema, vessels, and the friability and ulcers. It's into 3 grades: mild, moderate, severe, or 1, 2, 3. In mild, there is mild erythema, and there is a lot. Sorry.
Slides.
Right. In moderate, there is marked erythema and loss of vascular pattern and friability with erosions. And in severe, there are ulcerations and bleed. Now, Mayos is very commonly used and it gives us good assessment of the disease activity. But there's a problem with the Mayo score that it doesn't really truly reflects the disease burden. I'll give you an example. If we have when we have a patient with pancolitis, we put him on treatment, say infliximab, and we follow up a colonoscopy after 8 weeks or 12 weeks, and we see there is endoscopic recovery. But even if there's one ulcer present in the rectum, it will still be labeled as Mayo Endo 3. So this is one of the major drawback of this, that for any scoring we learn with time. So this is a caveat with this. So to overcome this, a suggestion has been made in which a modified Mayo score has been proposed, which takes into consideration the disease burden in different segments. Here the colon is divided into 5 segments: rectum, sigmoid, descending, transverse and ascending. And here we take 2 things into consideration, that whether all the segments have been visualized and what have been the Mayo scores in different segments which have been visualized. And based on this, we calculate extended Mayo score, which is calculated by whatever Mayo score we see in the segments which have been visualized. For example, if we visualize rectum, sigmoid and descending and we have a score of 3, 2, 2, it comes to 7. And if we have visualized all 5 segments, it will be 35. Then we divide it by the number of segments which are actually inflamed. So this gives us something like a true disease burden, and this is more correlation with clinical, biological and histological disease activity. Now the other score which is commonly used is ulcerative colitis. You see endoscopic index of severity. The parameters are the same. Only thing is, when we talk of Mayo score, as I mentioned, that there is a severe means there is hemorrhage and ulcers. But there's no stratification of ulcers into superficial or deep ulcers, and hemorrhage means hemorrhage there. So hemorrhage can be mucosal hemorrhage can be mild or severe. So these are the advantages of UCEIS. This takes into consideration the vascular pattern, which is obliterated whether it's patchy or diffuse, and the bleeding is again divided into mucosal and luminal. Luminal is mild or severe. And ulcers, again, whether they're erosions, 5 millimeter, or larger, if they're superficial, fibrin covered, the superficial ulcers, and if they're exacerbated ulcers, we label them as deep ulcers. So this has a total score of 8. So this was about ulcerative colitis. Now coming to Crohn's, the 2 scoring systems which have been tried, which have been in practice, the Crohn's disease endoscopic index of severity, which is again based on deep ulcerations, superficial ulcerations, total surface area which is involved by the disease, and the total area which is ulcerated. But somehow this is quite complicated and difficult to calculate and has not been very popular. The one which is more often used is simple endoscopic score for Crohn's, which takes into consideration the size of the ulcers, whether it's less than 5 millimeter or whether it's less than 5.5 centimeter or it goes up to 2 centimeters, then we give a score of 3. We take into consideration the total area of segment which is inflamed and the total, then the surface area in each segment which is actually ulcerated. Here we divide again into 5 segments: ileum, right colon, transverse colon, left colon and rectum. And each segment is given a separate score. And out of 56, which is the total score, we divide into remission or mild, moderate and severe. More than 15 is taken as severe. So here also what we have noticed with time, that each parameter is given a same weightage. Now each parameter may not have a same predictability for sustenance of remission. So to overcome this, there has been a modification which considers the same endoscopic parameters and anatomical locations as SCSCD, but acknowledges the different prognostic value of each parameter by assigning an individual weightage to each category based on impact on probability of achieving endoscopic remission. Now this can be calculated by online calculator. Now coming to the example that how it works, if a patient has a score less than 14, it predicts that there is a 66% chances that person will maintain remission at end of 1 year. While if score is more than 33, it's 13% chances that the remission will be sustained at the end of 1 year. So that way this modification has prognostic value. Coming to capsule endoscopy, there's a session on capsule endoscopy later on. I'm not going into this. We know that we take into consideration the villus architecture and the stenosis and the ulcers. And there are two scoring systems which are existing: capsule endoscopy CD activity index and Lewis score. Lewis score, if it is less than 135, we know its patient is labeled as in remission. But only problem is that this score has been calculated for inflammatory conditions of the small bowel, not exclusively for Crohn's. While CD activity index is focused for Crohn's, but there are no cutoffs that when to label a person as having mild, moderate or severe disease. So this was regarding the active disease. Now coming to remission. Now many things have happened over the years that initially the scores which were there, if the score was not there, like score was on the lower end of the range, we took it as a normal or person is in remission. Like Mayo score, if it is inactive disease, that was taken as a remission. But we know that with time, the endoscopy has moved from white light to high definition endoscopy and digital and optical enhancement. And the treatment goals for IBD have moved from just mucosal healing to even histological remission. So with time, we have different endoscopes, as Dr. Nagi mentioned. We have NBI, we have light, just linked color imaging, and we have eye scans. Now these chromoendoscopies, they don't just go into the presence or the absence of the vessels. They look at the pattern of the vessels. So this is the difference between the white light and the enhanced endoscopies. Like in NBI, we see whether there is a honeycomb pattern or bare branching pattern or the blood vessels are like veins. In LCA, we see the extent of the redness. It's a redness index. And in eye scan, there can be enhancement, surface enhancement or tone enhancement. So what are these various chromoendoscopies doing? Now, they can go up to a depth of 50 to 250 micrometer and they can see the pattern of the vessels and erosions in the mucosa. So based on this, even if endoscopy apparently looks normal, but people who have a dilated vessels around the crypts on eye scan, now if we correlate it with histology, there are more chances that patients who have dilated vessels around the crypts on eye scans are likely to have histologically active disease as compared to those who do not have. You may be surprised to know that what you see endoscopic remission on white light, 40% of these patients may actually have histologically active disease. In continuation with the same, confocal laser endoscopy and endocytoscopy are the other two techniques which are very much there, but still gastroenterologists, as such, we are not really making use of these techniques, but I'm sure in coming years, they will be used more and more. These CLE and endocytoscopy, both, they go up to looking at crypts, crypt distortion, the placement of the crypts, and even to the nuclear level. Similarly, we have now fluorescent molecular endoscopy, which correlates with the prediction. It can predict the responsiveness to the different agents. Now, if the cells have more expression of TNF, we know that these patients are likely to respond to anti-TNF therapy. Artificial intelligence, as Dr. Nagi mentioned, this can remove the subjectivity and inter-observer variability. So there is a score based on this Paddington Histological Remission Index, in which we can go up to actually a neutrophils in the epithelium and in the lamina propria. So now we can say that endoscopy is trying to be very close to histology. So what we have seen that white light still remains the core of endoscopic evaluation today. All of us are used to say Mayo score and UCEAS. I doubt if all of us are, including us, we are still not practicing SES CT for all patients, but I think we should, it's time we should. And it's time that we have to move from white light to high definition endoscopies with optical and digital enhancement. And in coming years, endoscopy is going to be quite close to histology. Thank you. My statements, if I can just read, that the statements which were given to me, I don't need to make any, I don't have any changes to make in this. And these three statements were given, I think they're fairly okay.
Thank you.
Right, thank you.
Now we move on to the last talk of this session by Saurav Kedia. Endoscopy for special situations like acute colitis, pregnancy and pediatrics.
Good morning, everyone. My sincere thanks to Reddy sir and Rupa ma'am for this opportunity. So I have to talk about the endoscopy in special situations, acute colitis, pregnancy, and pediatrics. So I'll start off with the role of endoscopy in pregnancy. So if we look at the indications of endoscopy in a pregnant patient, they could be related to IBD, which could be the first presentation. So to diagnose IBD, and a patient who has established disease, in a patient who relapses to confirm the flare, rule out infections, and rule out alternative diagnosis. There could be other indications as well, which could be unrelated to the IBD, which can occur in any pregnant woman, including GI bleed, vomiting, CBD stone, dysphagia, and suspected malignancy. However, here we limit only to the indications pertaining to IBD and pregnancy. Now, if we are discussing this topic, then what are the concerns which are related to endoscopy in a pregnant patient? It could be related to the use of sedatives, which could be given before endoscopy, the issue of bowel preparation, the maternal position, which could reduce the risk, the duration of procedure, and the effect of endoscopy itself on the pregnancy and the mother, including the effect of scope of the procedure duration and the scope traction on the uterus, as well as the timing of pregnancy where the endoscopy is suitable. Now, when we consider endoscopy in a patient with pregnant, in IBD patient who is pregnant, we need to balance two things, the disease activity. So we all know that it is the disease activity at the time of conception and pregnancy, which is the most important determinant of the outcome for both the mother and the fetus. So it is recommended that patients, if they are planning pregnancy, they should be in remission before conception. And even in this cohort, up to 1/3 of patients may have a disease relapse during pregnancy. So optimum disease control during pregnancy will improve the maternal and the fetal outcomes. If we look at the risk of endoscopy, then we have limited evidence regarding the safety of endoscopy in pregnancy, especially with regards to IBD. They are mostly case series or reports, only one prospective cohort study and one population-based study, and there is one confounder. So endoscopy is usually done in patients who have active disease. So whether this active disease, which is related to the adverse outcome, or is it endoscopy, which is related to the adverse outcome, it's still very hard to dissect out the difference between the two. So now let us look at the evidence related to endoscopy in pregnancy. I'll only be discussing about the risk of the lower GI endoscopy in patients with pregnancy. So this was a systematic review published in 2015, which looked at the overall lower GI endoscopies in pregnancy. So it included 2 retrospective cohort studies from the same group. So the first study had 48 sigmoidoscopies and 8 colonoscopies, which was compared with controls who had similar indications for these procedures. The authors concluded that the birth outcomes were similar between cases, controls, and also was similar to the general population. There were 4 fetal devices, but which were considered unrelated to the endoscopy. The second paper by the same group included 20 colonoscopies, of which 16 were done in the second trimester, and there were 20 controls again with similar indications. So the outcomes in the colonoscopy cohort was poor with respect to the general population, but this was attributed to the disease activity. That is the indication for which the endoscopy was done. However, when compared to controls, the outcomes were slightly better. There were 79 case reports in this review with 100 procedures, and they were similarly distributed across all the 3 trimesters. Overall, there were 6 adverse events which were related to the endoscopy during pregnancy. But again, there was no difference with respect to the trimester when which the endoscopy was done. Has been the largest cohort study related to the evidence on endoscopy in pregnancy published in gastroenterology, which included more than 3,000 pregnancies exposed to endoscopy and was compared with about 15 lakh pregnancies which were not exposed to endoscopy. And around 1,100 lower GI endoscopies were done. The outcomes which were looked at was preterm birth, stillbirth, small for gestational age, congenital malformations, the low birth weight, Apgar score, and the others. In this study, the authors also went ahead and corrected for the disease activity, which can be a confounder in interpreting the results of endoscopy on pregnancy. So they compared the cohorts both with and without active disease, and also they compared the endoscopic outcomes in patients who had endoscopy during pregnancy with those who had endoscopy within a year of pregnancy to match the disease activity. And they also looked to try to compare for the intrafamilial or the genetic confounding by comparing the outcomes within the same mother. So what the authors concluded was that if we look at the preterm birth, then if we look at the entire cohort, then the risk was higher in the pregnant patients. But when only healthy women were considered, the risk reduced. Similarly, if we look at the stillbirth, then only when the individuals with GI disease was considered, the risk of stillbirth was high, and similar was that for the small for gestational age. So the authors concluded that endoscopy during pregnancy is associated with increased risk of preterm birth or small for gestational age, but not congenital malformation or stillbirth. However, these risks are small and they are likely due to intrafamilial factors or disease activity. Now coming on to the evidence in IBD. So this was a prospective cohort study published in Journal of Crohn's Colitis, which included 42 cases with 47 endoscopies and which was matched 1:1 with controls with regards to age, disease activity and medication. So about 3/4 of patients in both the cohorts had active disease. About 50% patients received sedation. The endoscopy led to change in treatment decision in 75% of the patients. There were no maternal adverse events. Again, the number of procedures were similar in all the 3 trimesters. And we look at the fetal outcomes, then though the median birth weight was lower in the cases, but overall fetal adverse events, proportion of low birth weight, preterm delivery, congenital malformations were similar between cases and controls. And if they look at the total of number of spontaneous abortions, then they were less in cases who underwent endoscopy as compared to the controls. This was a study published 2 years back, which again looked at 48 patients with who underwent sigmoidoscopy or colonoscopy. The maximum number of procedures was there in the second trimester. Again, the authors concluded there was no hospitalization, no pregnancy-related adverse event, and only 1 stillbirth and 1 elective termination which were unrelated to endoscopy. And in about 80% patients, endoscopies resulted in the treatment change. So if we summarize the evidence, there is still limited data on the safety of lower GI endoscopy in pregnancy. However, the outcomes are independent of the trimester in which the endoscopy is done. Disease activity is the major determinant of outcome, and endoscopy can impact treatment decision if done for an appropriate indication. What do the guidelines say? So this is the most quoted, the AIG 2012 guideline, which talks about sedation in pregnancy. The lowest possible dose should be used, and meperidine and propofol are categorized as category B, Ventolin, midazolam as category C. However, the lowest possible dose should be used. Topical anesthetic can be used safely, and it summarizes that none of the currently used anesthetic agents, when used in standard concentration at any gestational age, have any teratogenic effect in humans. About the preparation, unprepared sigmoidoscopy is preferred. Only colonoscopy should only be done when it is indicated. PEG should be used. Sodium phosphate solutions are avoided. And the AIG 2012 suggests that the endoscopy should be deferred to the second trimester, only 1 minute. And the procedure should be done in the left lateral position, and the supine procedure should be avoided. The contraindications for endoscopy include placental absorption, imminent delivery, ruptured membrane, and uncontrolled eclampsia. The recent AGS clinical care pathway for pregnancy, it suggests that endoscopy in pregnancy should be performed for stronger indications to determine the disease activity and when the result will result in management. Flexible sigmoidoscopy is preferred over pan colonoscopy when possible, can be performed unsedated, unprepared, and in any trimester. The latest ECO 22 guidelines suggest that during pregnancy, endoscopy can be performed when needed to guide clinical decision making, And capsule endoscopy during pregnancy is considered a relative contraindication because there is no evidence on the safety of capsule endoscopy in pregnancy, only 2 case reports. About endoscopy in acute severe ulcerative colitis, it's again for diagnosis in an index presentation and to assess the disease severity and ruling out infections in patients with established disease. Unprepared sigmoidoscopy with minimal air separation needs to be done. Biopsy to be obtained from the area of maximum inflammation and full length colonoscopy and preparation to be avoided. About the pediatrics, so this is the 2018 guidelines on endoscopy in pediatric population. Most of these statements are similar to the adults, except that in patients, as Vishal has already talked about, in patients who we need to diagnose, so diagnostic evaluation for suspected IBD in children should include a combination of upper GI as well as colonoscopy. The other statements with regard to the endoscopic monitoring, small bowel endoscopy, therapeutic endoscopy, and cancer surveillance are similar to that of the adult population. So these were the statements related to this section. So endoscopic evaluation can be considered during pregnancy for new onset of bloody diarrhea, severe flare of IBD not responding to dose escalation. Full-length colonoscopy and bowel preparation should be avoided. Second trimester is considered as safest period for colonoscopic evaluation if required. However, if we look at the evidence, then if the patient needs endoscopy, then has active disease, then deferring to the second trimester may not be advisable. So we might need to modify this statement, or we can mention in the discussion as per the consensus of the House.
Thank you, Saurav. Now this is open for discussion.
Should we mention the experience of endoscopist in the active disease?
I think Dr. Nijavan, should we just put up the statements that were generated and we can go one by one and then edit if needed?
Am I audible?
Yes.
So you said that colonoscopy should be deferred to the second. There are certain conditions where you cannot do that. If a patient comes with an acute flare, you're not sure whether it is C. diff, whether it, of course, C. diff you can do by the toxinous, etc. If the patient has been on steroid earlier, you want to be sure you're not dealing with CMV, in which case you mandatory to take a biopsy. These conditions have to be referred. I mean, there must be a caveat. It's all very well to say that yes, they should be done in the second trimester, but the caveats should be mentioned.
Yes, sir. That is why I highlighted it in red, because it might need a change.
For biopsy, you can take by doing sigmoidoscopy only. There may not be a need for full length.
In first trimester, what's the risk of doing a sigmoidoscopy or colonoscopy? You can do a colonoscopy. You can do a sigmoidoscopy. Is it more safe than doing a colonoscopy? First trimester, I'm talking.
Sir, in all the trimesters, if sigmoidoscopy is sufficient, then colonoscopy need not be done. It's only when sigmoidoscopy is colonoscopy, we need to look at the terminal limb of the right colon, then only we should do the colonoscopy. Otherwise, unprepared sigmoidoscopy is the safest procedure in any trimester. With regard to trimester, the evidence is limited, but it suggests that endoscopy is equally safe in all the trimesters. So if it is indicated, we need to do it irrespective of the trimester.
Why I'm asking is, doing a rectal stimulation or rectal manipulation can enhance the abortion in the first trimester. So is it that when doing a sigmoidoscopy, it's itself that can do that?
Sir, it could be, but with the available literature, wherein there are 2 studies which have equal number of procedures in all the trimesters, the limited evidence suggests there is no elevated risk. So if a patient has active disease and requires change in management, and if endoscopy can impact the management, then might be done when it is indicated. So deferring till the second trimester
Essentially what you're saying is you have to see the risk-benefit ratio. I mean, if you think the benefit is going to be more, then go ahead and do it. I think that's what it is.
Yes, sir.
Are we going through the statements now, Rupaji?
What has been done so far is we've just followed the Oxford criteria for the level of evidence on the statements that were generated. So I think the statement needs to be the big thing here. So we can just go and see whether we need any edits to the statement. Can it go as is, or how we can modify it? And whether any additional statements need to be put, whether, is it safe enough to highlight the same. So just focus, because the level of evidence just need the consensus, but the top question is what is the most important. So Dr. Vishal, can you just...
Yeah,
So
Rupa,
for example,
can I make
for
a
the-
point here, Rupa? We have to look at the statements in 4 contexts. One is the initial diagnosis, then, disease burden assessment, which may not happen at the same sitting, and then response to the therapy, and then surveillance. I think when we are talking of endoscopy in IBD, we need to have statements based on what we are trying to achieve. But what you will do in the initial disease diagnosis may be different from what you will do for disease assessment, disease burden assessment later on.
Yes, sir, I think what you're saying is absolutely right, sir. But what we are going to do right now is a few of these statements, whether we agree or not. After that, this will be extensively circulated, because there will be some overlap of statements between different sections. But for discussion purpose, we made it into diagnostic, biopsy, and then finally into therapeutic procedures. So,
for most of the statements, as you will see, that the level of evidence is not much, because for many of them, either RCTs or systematic reviews have not been conducted, or if they are available, they have addressed indirectly those issues. For example, for the first statement, ileocolonoscopy is the initial investigation to establish the diagnosis and extent of suspected IBD. I think this is a fairly clear-cut statement, and we really don't need to look at the evidence, because ideally you have an ileocolonoscopy and you should have a gold standard, which should be surgery or followed by histopathology, which would not be available, that kind of study. So now what we have is that there is no SRMA or no meta-analysis which directly addresses this question. But there was an umbrella review. So umbrella review is a review of systematic reviews which addressed multiple parameters against ileocolonoscopy. So this is indirect evidence. The best performing parameter was fecal calprotectin. So that is why I have taken a meta-analysis which looked at fecal calprotectin as compared to ileocolonoscopy. And you can see that there are 19 studies. The gold standard was ileocolonoscopy plus histopathology. Overall, the risk of bias in this meta-analysis was low. There was inconsistency because of high heterogeneity, although there were multiple subgroup analyses which could not directly address it. There is a very clear indirectness, because our study question is different, and this addresses a very different kind of a question. So this is an indirect evidence, and the estimates were fairly precise, the sensitivity and specificity. So the certainty of evidence would be low. Now, why low? Because for diagnostic accuracy studies, you start off with a high, even if it is observational studies. For an interventional kind of meta-analysis, observational studies would be low. So you would go to very low. But here you start off with a high, you downgrade by 2, and therefore it's a low certainty of evidence. So this has been followed using the grade methodology. Now the problem, of course, is that fecal calprotectin has fairly good sensitivity, and it was robust even on subgroup analysis, but the problem is with the specificity. We know that it increases in other infections, ITB, CRC.
I think, Dr. Vishal, I think, just pardon me for interrupting, but the thing is, what we felt that because of this, esteemed panels here, we will just have the summary of what is the, how much we agree, but the focus we want is on the statement and whether people agree. If we agree, then we will, of course, it will be open for edits in future, but in principle, should we add anything else, or is that the statement?
But Rupa, I'd like to qualify that this particular study, umbrella review, doesn't fit into the context of this statement. Because this is the initial diagnosis. It's not a looking at a relapse or recurrence or anything. So this particular study of umbrella review of calprotectin doesn't,
So these were
we
for,
never-
yeah, I agree that this was for diagnosis, but the problem is this is very indirect.
No, that's right. So I said no relevance actually.
You see, for
The only thing is
diagnosis-
that if you make a statement like that, my only suggestion is, maybe it will I have no objection to the statement. This is absolutely right statement. That maybe somewhere we should write on the discussion that in a patient with a severe disease, sigmoidoscopy is good enough, rather than saying ileocolon.
Don't put
It
initial.
depends on the
Remove
presentation.
initial from your statement.
Because fecal calprotectin cannot be considered as equivalent to colonoscopy for making a diagnosis of IBD.
it is for monitoring.
At the initial time. Maybe on follow-up, if the patient is symptomatic, then you can look for the flare causes, and of course, fecal calprotectin may probably tell us that this is a flare of disease. But for initial diagnosis, that should not be made. I think you can add on that, or not for initial diagnosis, something like that.
So this,
Either,
You can add surrogate marker.
no, either you remove initial or you add ileocolonoscopy, oblique sigmoidoscopy.
I think this statement is like for any patient taking a history and examination. This is that basic.
so I think, yeah, I mean, very easily we can say that on basis of expert consensus and, this statement can be carried forward. Because if we are not going to find any direct data or, a very robust study to, deal with this.
I'll just suggest one.
No,
I
No,
think
Naresh,
here
can
instead
I-
of
can I-
diagnosis, the word should be suspicion. Because the test has high sensitivity but low specificity.
So,
So
ma'am-
in the presence of elevated calprotectin, you should do an ileocolonoscopy to establish a diagnosis.
That would be a separate statement if we want to, bring calprotectin also inside.
No.
So for this, I think it's
I
very
think
clear
here
that it
we
is
are
a
not-
suspected IBD.
I think here we are not going to go for calprotectin at all.
Yes,
I
yes,
think
I
we'll
think-
stick to the original statement and
That's
we'll
better.
put
And,
the edits that it should be colonoscopy and it should be suspected case.
one more thing,
Ileocolonoscopy.
one more thing, Ruba. Can we? No, sorry.
Can we project the statement and then modify it?
And
As we are
ileocolonoscopy
discussing.
for ulcerative colitis and ileocolonoscopy for Crohn's disease. Should you differentiate that? Because suppose there is a left side colitis, do you need to do an ileocolonoscopy? Do you need to?
Should be oblique
Yes,
sigmoidoscopy.
the first. That means, no, that means in the index, first diagnosis. Suppose, in the patient you are doing a follow-up colonoscopy, and in that case, if it is an ulcerative colitis, there are, of course, certain risk factors for doing ileum. For example, in children.
think
The
we can
only what was suggested, I think, is that in active colitis, should we, in the same statement, mention in absence of active colitis? So otherwise, are we trying to say that all patients in...
That should be a separate statement. That should be a
Yeah,
separate
but then
statement.
this statement of ileocolonoscopy is the initial investigations to establish the diagnosis and extent of IBD will not hold true when you are dealing with active colitis or severe colitis. Severe colitis.
And that should be added as a second statement, in cases of acute severe
The
colitis.
statement remains, we just mentioned that in the discussion part.
Yes.
I think that will be better, that we just mention that in the discussion part.
In left-sided, Dr. Matthew, in left-sided colitis, ileoscopy is indicated only if you have a cecal patch.
That's what
Otherwise,
I'm telling.
it is not indicated.
That's why there are high risk factors.
When you cecum, if you have inflammation, then you go into the ileum. Otherwise, there is no.
See, there are obvious high risk factors for doing a ileoscopy in ulcerative colitis, only cecal patch. Other is children. And
It's like the ileocolonoscopy is the initial investigation establishes the diagnosis and extent of IBD. So what is the recommendation from the group and what is the level of evidence?
Recommendations,
The
I think
statement may be 5.
they are going to finalize later on. Vishal, if you just write endoscopy.
Otherwise, we keep on adding so
If
many
we just
things.
write
We
the
can
word-
increase the number of statement.
If you just write the word endoscopy is the initial investigation.
no, but
That's,
Ajit Sood, if you look at the Naresh, if you look
Vishal,
at the
just write endoscopy is the initial investigation. What is the
Yeah,
problem
yeah,
with that?
yeah.
Endoscopy, whether we are doing left-sided or Limited scopy doesn't matter. Endoscopy, it's the endoscopy.
Endoscopy means gastroscopy also.
And if
Right, endoscopy which would be
colonoscopy
no,
oblique
this,
sigmoid.
no, you look at the sentence and look at the previous consensus. Everybody has written 100% consensus on ileocolonoscopy is the initial investigation of choice. No, that's what I'm telling you, you can echo consensus. What is written? The first sentence, ileocolonoscopy is the test of choice.
No, I
and it's
think,
100% agreement.
I think we are discussing too, because the problem is we have 3 more statements and time is just another.
Uh,
So what
Vishal-
I'm suggesting
Vishalji,
is
I
very
have one-
brief and just simple statements, and any modifications required, they'll write down and then they will. So whatever modifications, he will write down and then.
This severe, it has to be acute severe colitis or severe acute colitis, not active. Acute, where the colonoscopy could be risky.
Severe acute.
Yeah, you should say acute.
So coming to the next statement.
Vishal, in this discussion, I think we should mention about the situations where in acute, ulcerative colitis, where all should mandatory that you should go for ileal study and all. I think that is important in discussion, not on this.
Mentioned in ECO is it is a level of evidence 2 rather than if we do grade evidence, then it will be very low, but if we use Oxford, it will be level of evidence 2.
I think we should, I think what Partha is saying, I would agree. We should just do it as per the ECHO guidelines and have the level of evidence, because that is going to be at least...
The benefit of grade being that it is a very transparent process. And
but it will be very difficult, I think.
It's a very, a stepwise kind of an algorithm. The Oxford is very, very blanket. You have a meta-analysis, what are the contributing studies? There's no talk about that. You have a RCT, what type of RCT, what were the biases? Nobody talks about that. So Oxford, I think there are problems. It is done for the ease of doing. So if we want a very robust kind of, thing, then I would suggest grade methodology be used, but it's
I agree, Vishal. So let us do one thing, sir. Right now, the statements that are generated or what has been suggested by everyone will be shown. All the points will be taken. And at the end of it, Dr. Vishal and Dr. Partha can sit together and see whether which criteria fits in, and we will share with everyone the level of evidence. Because if we get into every statement, then we will not be able to. Just only to mention.
Speaker can tell about the level of evidence but cannot grade the recommendation.
So you mention the level of evidence, but don't tell us how much and why you got to that level of evidence. You can say that this is the level of evidence. We will note it down. Which criteria we will follow in the ultimate publication, we will share with you that according to the different criteria, what level of evidence we are getting, and then we will come to a consensus on that. So I think if we agree on that, then we'll proceed.
Agreed, that is agreed. But Devendra has told a very pertinent comment that when you send it for circulation, less than 50% answer or comment on that.
Oh no, don't worry. I will call everyone up and ensure that.
Rupaji, I think when you are giving a statement, give like this a table with the grading and the studies.
Yes.
So that everybody is clear. Why we came to this consensus on.
Okay. No, when we are sending it, we will have all of that. Right now, statement and discussion and all points that are said by individual people, Dr. Partha, Dr. Vishal and Dr. Raj, all of them are just noting it down and will be shared that these were the suggestions. Accordingly, this is the... So, Dr. Vishal, can we go with the second?
Second statement is concomitant upper GI endoscopy should be routinely performed for suspected pediatric and adolescent Crohn's disease. It can be done in adult Crohn's disease if there is a clinical suspicion of upper GI involvement. So there is no meta-analysis or a systematic review which addresses this question, but there are multiple studies which have looked at pediatric IBD And you can see that this is the important thing. Sorry. Sure, sir. So if you look at the additional diagnostic yield, it is like almost around reaching up to 10% in most of the studies for pediatric Crohn's disease. So this is a place where a meta-analysis can be done, a systematic review or a meta-analysis can be done to address this issue. But this is the statement that we have.
We don't have any data on the adults.
So there are a few studies, but the guidelines do not suggest, I mean, whatever guidelines are available, they say that you should do it in symptomatic. And in fact, the eco consensus suggests that you should not do it in asymptomatic.
I think this statement can be passed as such.
Should we change this?
No, I think Dr. Jayanti is talking about the second part of it. Okay. It can be done. Instead of that, it's she says that it's indicated. Is that right?
Why?
Oh, no. Cannot be considered
Sir,
as
I
malpractice.
think this is a much improved statement over the, routine recommendation in IBD. So here it is specific for Crohn's disease.
I think it should be there because upper GI endoscopy should be done in patients with Crohn's disease, especially teenagers, adolescent and children, because that makes a lot of difference for making diagnosis, which when I present, I will also make a comment on, suppose you get a biopsy on antrum, that is granuloma, will you change your molecular classification? There are all certain things which has to be really thought about this.
Yeah, it is indicated.
It's recommended. For children, it's recommended.
For adults, it is indicated in adult Crohn's disease if there is.
So the next, for initial diagnosis, at least 2 biopsies should be taken from 6 segments, even in absence of macroscopic disease. Unfortunately, no systematic review or meta-analysis could be identified which address this question. So we can take up this statement.
This actually, I think, needs discussion. That what do we feel?
How like I don't think anybody in India will practice in ulcerative colitis taking so many segments. So which we. No, it does not. In ulcerative colitis, no. In patchy segmental Crohn's colitis, sometimes it may be able to pick up where the other spots may miss. That is the only indication for taking multiple.
I think in our setup, we also need to look at cost effectiveness.
Yeah, it is very costly.
On endoscopy, then they have taken the 2 biopsies from the 6 segment, even in the absence of macroscopic.
No, but
No,
again,
I think in the index colonoscopy, we should actually take multiple biopsies.
no, but the thing is, again, I come back to the same. When we say for initial diagnosis, I'll ask you how many times in a ulcerative colitis, when it's coming for index presentation, you do a complete colonoscopy. So are we doing sigmoidoscopy or are we doing complete colonoscopy after preparation?
No.
Yeah, but
No. Suppose you are seeing only a left-sided colitis. Will you take a segment biopsy everywhere? No. But in Crohn's disease, I think this statement is very important that you should take, and also you should take, even if the rectum is not involved, rectosigmoid is not involved, you take should biopsy. Because a right colon disease can have, Crohn's disease, and some days you get granuloma in the rectum or rectosigmoid. And that will also, we will get a differentiation for TB and Crohn's. That is one of the important criteria. But I think, at least in Crohn's, we should recommend that we should take biopsy from all these areas. In ulcerative colitis, I think that you can.
Left-sided colitis.
Yes, I do. In Crohn's. In Crohn's disease, yes, we do that. But one more thing, let me ask. should we also write down from where the biopsy should be taken, from the ulcer margin or from the base or from the surrounding region?
So
Actually, we in Crohn's and all, like for example, if you're doing in an inflamed area, you should also take from the uninflamed area also. That has been very clearly shown.
sir, I think for the initial diagnosis, it
Two
is very
separate
clear.
bottles wherever possible, but each segment we put in one bottle because it's expensive. So what we do in practice, we do ileal biopsy, cecal biopsy, then transverse colon and rectum. That's it. No descending colon, sigmoid, so many segments.
Sir, I think Dr.
Separate bottles.
Sood showed that slide that even on simple white light endoscopy, you miss inflammation out. So that makes a case for taking biopsies.
The normal.
See, I think I remember a study in which it was shown that whatever you see on white light, without high definition, the microscopic extent is at least one segment ahead. So if you go by that, and that is the standard practice, that you will biopsy normal looking area also. If you are doing a pan colonoscopy, you have to take biopsies from each of the segments. At least 2 biopsies. That should be, I mean, we are
The
talking
discrepancy between endoscopic extent and histologic extent is very well recognized.
So why are we hesitating only for cost factor? Then if we are hesitating at this level, how will we reach surveillance?
Yeah.
When you need to take over 30 biopsies.
Can I tell one thing?
No, and
Can I tell one thing?
No, can I? One more thing is that no, cost should not compromise our consensus opinion.
Can I suggest one thing? What we are talking is our experience. What we are talking there is what is evidence. When we are labeling it is what is the level of evidence available. What we are doing in the practice, we are not writing on these guidelines.
And what we should
I
do.
think, just a second.
Yeah, but if there is any evidence, we can only change if we have an evidence to say that yes, by taking the only 2 biopsies from any segments, we are proving it. There must be a data supporting this. You have to take from each segment.
Yeah, Rajesh,
and the
I
person who
agree.
is
See, I just want to interrupt and say that there are about 2,000 viewers for this meeting now going. About 35 countries, we're getting a lot of messages. So we'll have to discuss only very evidence-based, not personal opinions, because we're getting some comments saying that not personal opinions. So I think it has to be like you suggested, only evidence-based, whatever is there in the evidence. Practice may be different sometimes, but I think this is a forum where you can't do that. It's a different forum. The next question, I think.
So biopsies of involved segments should be taken during flare to rule out superadded infections like CMV and tuberculosis. So I could identify a meta-analysis which addressed the question of use of histopathology for the diagnosis of CMV reactivation. And it found that there was although a poor sensitivity, but very good specificity for the diagnosis of CMV reactivation when histopathology is used. However, the problem with this systematic review was that the gold standard was either a IHC or a tissue PCR, which the best gold standard would have been a therapeutic response to ganciclovir, and that kind of a comparison for histopathology was not available. So this has been downgraded for indirectness. And the overall certainty would be very low, but it is an important statement. Again, similar kind of data could not be found for tuberculosis. We can have a discussion on this statement.
I think this statement should go through, no?
This can be passed as such.
In your evidence, you mentioned that there was enough about CMV, but there wasn't any evidence about tuberculosis. So then when you give the grade for the statement, it will be for both CMV and tuberculosis.
So separate statement should be.
Discussion.
Any other comments?
We are specifying only CMV and tuberculosis. What about C. diff? It should be any infection. I think, I mean, one should suspect a super infection, amoebic infections for us.
But
that's
C.
more
diff
important.
For histopathology,
no, C. diff you don't require a biopsy. You need a toxin.
So we are talking, Jayanti, this statement is about biopsies in colitis. This is not about stool examination.
So the next statement again doesn't have evidence, systematic review to support it, but biopsy should be performed in assessment of pouch related symptoms, the anastomotic site, body of pouch, tip of J pouch and pre-pouch ileum should be examined and reported separately.
This is fine.
No, there is no evidence for tip of the J. There is no evidence at all that you need to biopsy the tip of the J. I think the same topic statement has been sent to me, so I have covered this. I agree with this. There is no. Sorry. You will examine the whole pouch. You don't say that you examine the tip of the J and the apex and everything. You just say examine it. No, but there is no report. There's nothing that the tip is going to tell you.
Dr.
The
Vishal,
tip is a part of the
Can I make
efferent loop and it is addressed in the efferent. You don't have to mention there is.
Sometimes if there is a Crohn's disease or a cuphitis,
Cuphitis is on the other end. The tip is on the other end. So we are on the opposite.
Sometimes there may be a leak or sinus on the tip of the J. So in the post-operative setting, so that may be important.
If there is a leak, the last thing that you want to do is to take a biopsy.
No, not biopsy, sir. It should be examined and reported separately.
I think just the initial statement is fine. Biopsy should be performed to an assessment of pouch-related symptoms. I think that is sufficient.
Vishal, Matthew here. Should we add this on that when will you, it's only for symptomatic patients we that do a pouchoscopy, right?
So no, I think there are guidelines separately for surveillance. That will be, I think, taken up later, pouch surveillance.
I think there is no information for people as to when they are doing a pouchoscopy where they should take biopsies from. So sometimes if for an ulcerative colitis, it might be Crohn's, it might be cuphitis, it might be other things. So it would be good to have some sort of, agreement on where to take biopsies from. So the most involved part or the other parts as well. And I think if you're doing a pouchoscopy, makes it worthwhile to take one from the neoterminal ileum because there is a percentage which develops Crohn's later on, and these are symptomatic.
Rupa, I think in my slides when I come.
Okay, so we can go to the next, but as
so
of
we can
now,
amalgamate
put
the two
a
if there's
note over there that the sites to be discussed.
Site of biopsy needs to be
That I think there is a
and also
statement.
there are guidelines coming out that came with the pouch studies and all.
They're very clear guidelines.
Very clear guidelines.
Not on much evidence, but there are nevertheless there.
And also on the mucosal atrophy, where you have to see high risk factors.
Next.
In
This
routine,
I think does not need much, but you can
yeah.
just-
So I'll just briefly, in routine clinical practice, either Mayo endoscopic score or UCIS can be used for monitoring endoscopic activity in ulcerative colitis. So this was a Cochrane meta-analysis, systematic review which was available. And usually for such scores, you test across 4 things: reliability, validity, responsiveness, and feasibility. So these are partially validated scores, but nevertheless, out of the 19 scores which were assessed, different types of scores for ulcerative colitis, these 2 seem to be the maximally validated ones.
This can be passed as such.
This can be passed.
So the next, of course, is about the simple endoscopic score for Crohn's disease, and it can be used for assessing disease activity, endoscopic response, and remission in Crohn's disease. Again, there was a systematic review which assessed CDIS and SESCD, and both of the scores seem to be equally well assessed for reliability, validity, responsiveness. But for feasibility, the SESCD was not assessed. However, it was believed that it is easier to use because of lesser calculations. So usually this is suggested as the preferred score.
So I think because there's so many scores, it is better that we label that for routine practice, we should start using, and these are the few that we will use.
You want to mention Sood for SESCD? No.
No, not at the moment. There have been suggestions by the by authors. They need to be validated further.
So so this is about pregnancy. Full-length colonoscopy and bowel preparation should be avoided. Second trimester is considered safest period for colonoscopic evaluation if required. So again, the question was regarding IBD, but we have an indirect meta-analysis which Dr. Saurabh also talked about. and there were no estimates which were given. There were just 2 studies, basically 3 studies, and one of which was additional controls added and from the same group. So basically 2 studies, both of which suggested that there was no difference in outcomes when sigmoidoscopy was done. Although the outcomes were worse than the national average, but for the pregnancies, in fact, there were better fetal outcome in cases in one of the studies. So there is an impreciseness, indirectness, and inconsistency. So this is a very low quality of evidence, and also we do not have precise estimates.
I wanted to ask one question here for the panel. So what the evidence sort of, maybe a comment from you, the evidence that you showed, it showed that colonoscopy can be done in other trimesters as well. So should we just label it as second trimester or?
Safest.
For example, in the
safest in second.
So should we have a statement beyond that? Second trimester is considered safest period, but should we write over there?
If required.
No, why? Because you cannot postpone just like a surgery, elective surgery, a colonoscopy in diagnosis of IBD.
No, we are not postponing, but should we mention over there can
Not
be
required.
done in
You'll be
during
doing
any time in
colonoscopy.
pregnancy?
Yeah, you'll be doing colonoscopy.
If indicated,
systematic.
if indicated.
When any trimester is safe. Any trimester is safe if indicated.
Indicated,
you have to
yes.
do it. You have to do it.
Do we
It should
want
be,
to do we
it
want
should
to
be
include-
limited colonoscopy is,
It can be kept in discussion with subtext. You can have the
What Dr. Sood is suggesting is it should be limited colonoscopy can be done if required, and we should mention in the discussion.
So why this second came? Because the only comparative study in which there were 20 patients who underwent colonoscopy, 16 were done in second trimester. So that is probably the reason that has appeared. But again, that is indirect for IBD.
No. I think
Vishal, there are 2 things. One is urgent colonoscopy, one is elective colonoscopy. Elective is obviously in second trimester. If it is urgent, it has to be any time. No, in case somebody wants to know that diagnosis, or somebody now wants to see whether
should be avoided.
make some changes.
Elective should be avoided.
No, I think as Nagy told, we can put it in the discussion.
I'm not saying
The
that we put
the
these
evidence says
terms.
that.
You're right. See, it's not a contraindication, it's a high risk. So, but if it is urgent, I agree. I mean, it should be done.
So
Yeah, I'm not saying that we add-
usually in pregnancy, I think safety is a very important criteria. So if we have clear evidence that colonoscopy is safe in first and third trimester, we should be careful in making a recommendation to that end.
But Vishal, at the same time, disease goes unchecked, it is much more dangerous than
That is
colonoscopy.
obviously correct,
So
that
wherever
if
we
it is a matter of life and death, then it doesn't make a
wherever
difference.
we anticipate that it will change the course of the disease, it should be done. It should change the course of treatment, then it should be done. That's it.
So our sentence should be like this: the full-length colonoscopy and bowel preparation should be avoided unless until it changes the course of your management.
I think we
The
can
entire
just-
sentence should come.
I think it's.
Bas, I think that is important. Our sentence should reflect that what we want to convey.
But on discussion with gynecologists, they often say that the second trimester is the best for any form of sedation, any form of anesthesia, and for blanket. So what I'm saying is, when we are.
If it is indicated, then it has to be done, irrespective of the trimester.
No, I think the original statement is right. All this can be kept in subtext, full length, all that can go to subtext.
So
Should go in discussion.
these are the original statements, sir.
Yeah, we'll keep that, and then in the discussion, we will say that for urgent or other purposes, it can be done at any time. Right now, can we go to the next statement then?
This, again, this, I think this statement was probably not discussed, but endoscopy should be repeated for ulcerative colitis flares, including ASUC, to rule out concomitant infections. Again, there is indirect evidence from that CMV. Largely, we are doing it for CMV only. So
I think this will definitely merge later on with the other statement, so we can skip to the next.
I think that's for the first session.
Okay, I think we should.
So I think, yes, the first, Dr. Nijavan, your comments. I'm sorry because we just began. So.
Yeah, we had a good session and almost all the statements are passed. So whatever we had some discussion, that should go in the discussion part of those statements. And we should write the recommendations and the level of strength according to the literature which is available. Yeah.
So we meet at 11.
Two more agreement 100% by the people. Agreement.
There were two more statements which have not been discussed, I think. One more related to pregnancy and one related to acute colitis.
We should break and meet at 11 sharp again.
Yeah. There are two statements left which he is speaking. Partha.
So one was related to pregnancy. Endoscopic evaluation can be considered during pregnancy for new onset bloody diarrhea, severe flare of IBD not responding to dose escalation. And there was one related to acute colitis. In acute severe colitis, unprepared sigmoidoscopy without bowel preparation should be considered with biopsies from at least one side for diagnosis of acute severe ulcerative colitis and exclusion of other causes of acute colitis.
Dr. Devender, you will be moderating the session. You want to do it from there because then people can see you. You have a mic with you.
Who is moderating? Dr. Desai. Good morning. So I'll be talking about capsule endoscopy indication and contraindication. I was provided with some of the statements by Rupa, but I have modified some of them and I have incorporated them in my talk. So as discussed, I will present my talk and then we'll go through these statements and would want a comment on each of the statements. So there are about 8 or 9 statements related to the capsule endoscopy, which I have prepared. As you all know that we have been doing capsule endoscopy for quite some time these are some of the features of capsule endoscopy. But my first statement is capsule endoscopy is indicated to diagnose suspected small bowel Crohn's disease. What we can discuss, I think there's no controversy about this, but what we can discuss whether it should be after a negative ileocolonoscopy or in all cases. Why I'm saying so is that you have found a Crohn's disease in ileocolonoscopy, whether you should still map the disease by doing a capsule endoscopy or not. So that's why I've kept it in bracket. We can discuss whether this should be a part of the statement or not. Something is coming here asking me to log in. Okay. So this is a comparison. This is a meta-analysis. In fact, there are 2 meta-analyses which has compared the role of capsule endoscopy in suspected Crohn's disease in comparison with other modalities. And this is a meta-analysis of large number of studies which have compared with small bowel enteroscopy or barium follow-through, ileocolonoscopy, CT enterography, and MR enterography. And as you can see, there is increment yield of capsule endoscopy compared to all these 4 in this meta-analysis is 32%, 22%, 47%, and 10%. So obviously, in this meta-analysis, it has been shown that capsule endoscopy is better than all these 4 modalities for suspected Crohn's disease. Now, there was a second meta-analysis published in 2017, almost the same data, saying that compared to small bowel, barium will follow through and enteroclysis, ileocolonoscopy, CT enterography, and MR enterography, the capsule is comparable. Only difference was that here MRE was found to be slightly better than capsule endoscopy, but this study included only 2 studies as compared to the previous one, which included 3 studies. So there's a marginal difference in the 2 meta-analysis. So now recently small bowel contrast ultrasound has been used increasingly for diagnosis of a small bowel Crohn's disease. But this meta-analysis of 5 studies showed that capsule endoscopy still is better than small bowel ultrasound for the diagnosis of Crohn's disease in the small bowel. So I think that was the first statement. We can discuss whether that bracket should be kept or should not be kept, depending on whether we think that a mapping of the whole disease should be done in the very beginning or not. So the second statement is capsule endoscopy finding in small bowel Crohn's disease has to be interpreted in correlation with other features to differentiate from other similar appearing lesions such as tuberculosis, NSAID, enteropathy, and so on. Now, we know that similar findings can be found in Behçet's, vasculitis, NSAID, or other drugs, tuberculosis in our country, and even in healthy individuals, some of these findings will be found in 10 to 14%. In fact, there was a prospective trial which looked at 37 patients suspected to have Crohn's disease on the basis of capsule endoscopy, and only 13% were subsequently confirmed at 1 year to be actually having Crohn's disease. So, this was an ICCE criteria published almost about 10 years back, which divided 4 groups of findings. Group A is clinical, Group B is depending on the features of whether there is extraintestinal manifestations. Then we have inflammatory markers and radiological. And they say that A should always be present, and out of B, C, or D, at least one should be present to consider the diagnosis of Crohn's disease. In fact, this is a retrospective study which found that if there's no criteria and the capsule endoscopy shows Crohn's disease, only 21% will ultimately prove to be the Crohn's disease. If there are 2 criteria, 52%, and if three criteria, 77%. And this is a systemic review with meta-analysis which showed that even if there are features suggestive of Crohn's disease at capsule endoscopy, if the fecal calprotectin is less than 50, it's unlikely that this is Crohn's disease. So these were the 2 initial statements. The third statement which I wanted to mention is the scoring system at capsule endoscopy may be used to determine the predictability and severity of disease, somewhat akin to the conventional endoscopy scoring which we have talked about. So as was mentioned, there are 2 scoring systems which are done for capsule endoscopy Crohn's disease activity index. This is one which is also known as NIV score, which includes inflammatory score, extent of disease in 2 areas of the 2 tertiles of the small intestine. To be added to that is narrowing. So I'm not in the details of this, but the maximum score possible is 36. And this has been validated in multi-center prospective studies as late as 2018. So these are well-established activity index. The second activity index, which was also mentioned, is Lewis score, where you divide the small intestine at capsule endoscopy into 3 tertiles. And then you look at villus appearance, ulcer, and there is a way in which you calculate the score, number multiplied by longitudinal extent multiplied by descriptors. And to this you add the stenosis scoring. And this is a Lewis score which is incorporated within the capsule endoscopy systems nowadays. And it has been shown that below 135 is normal, 135 to 790 is mild disease, and more than 790 is moderate to severe disease. Now, in fact, this has been validated in a couple of studies, and these are good studies which show that in the first one, that if the score is more than 135, positive predictive value is 73%, and if score is less than 135, the negative predictive value is 92%. Similar data from another study. So that was my third about the scoring system. Now, my fourth statement is a cross-sectional imaging, either CT or MR. MR is preferred, or a patency capsule should be done prior to C. And I have written here in bracket only in suspected stricturing Crohn's disease. So point is that you need not do these in all patients with Crohn's disease, because then the cost effectiveness is not there. But if you are suspecting stricturing Crohn's disease, you should do one of the 2, either a cross-sectional imaging or a patency capsule. And the fifth statement, which is again related, is that in patients with established Crohn's disease, capsule endoscopy, though informative, is usually not preferred as the first choice over cross-sectional imaging due to risk of capsule retention. And I'll have some data to present on these 2 statements. Now, capsule endoscopy in established Crohn's disease, again, there's meta-analysis, which has shown that it is very good. In fact, if you look at increment of yield at capsule endoscopy compared to small bowel barium follow-through or a small bowel enteroscopy is 38%. For ileocolonoscopy for small bowel disease is 13%. With CT enterography is 32%. Only thing which scores over capsule endoscopy for established Crohn's disease is MR enterography, which is so the increment yield at capsule is minus 9%. But what was found consistently that capsule endoscopy is much better than CT enterography or MR enterography to the extent of 150% pickup for proximal small intestine. And this is again another meta-analysis which looked at all the 5 comparisons, and as you can see the diamond is on the right side. That means all of them preferred that Crohn's disease picks up more than any of these comparative modalities. The cross-sectional imaging, as we all know, have an advantage in patients who have stenosis to give you information about transmural changes and extraluminal disease. Now, capsule retention is a real problem, and these are multiple studies, both prospective and retrospective, which has looked at the capsule retention rate. For established Crohn's disease, it is up to 13%, can be even higher if they are obstructive symptoms. Suspected Crohn's disease, it should be 1.5%, and for obscure GI bleed, it is less than 1%. I'm sorry for that, it's 1.5%. So for suspected Crohn's disease, capsule retention is not a major problem, but for established Crohn's disease, it's a major problem. So capsule endoscopy generally not preferred for established Crohn's disease, except when there are no features of stenosis and there is patients with anemia, obscure GI bleed, or for assessment of mucosal healing. So what about mucosal healing and Crohn's disease and capsule endoscopy? This was a retrospective study, 43 patients. Of the 28 patients having baseline as well as 52-week study at capsule, as many as 42% were found to have complete mucosal healing capsule. So at least 58% did have positive finding at capsule endoscopy in spite of clinical remission. Similarly, there is a systematic review of 9 studies, 8 of them prospective, which have shown that capsule endoscopy is useful in mucosal healing assessment with no correlation with clinical activity. That means even if there is no clinical activity, capsule endoscopy may be positive, and there was a good correlation with Lewis score and the fecal calprotectin. Now, the last one on this aspect is that capsule endoscopy may show new proximal involvement with progression of structuring or penetrating disease with an impact on therapy. And in general, patient preference is over for capsule endoscopy compared to MR enterography. Now, this is a more recent data, 2021, which has said that CE is useful in evaluating mucosal. Highlight is that you cannot actually replace MRE for patency capsule. And you look at the data, that MRE has a sensitivity of 92.3%, but specificity of only 59%, as compared to the patency capsule of 97% and 83%. So if one has to depend on MRE alone, because of the specificity of 59%, you will unnecessarily avoid 40% from having capsule endoscopy. So patency capsule is good, but then we'll have to see availability and cost, though we discussed that we should not be talking much about the cost and the availability in this forum. My sixth statement is that retained capsule can be retrieved with device-assisted endoscopy with or without balloon dilatation. Surgery is only warranted if endoscopy fails or is not available. I think we all know that now with balloon endoscopy and with motorized spiral, you can remove capsule endoscopy. So capsule retention is asymptomatic in 85%, partial or complete obstruction in 15%. You may go conservative, give some therapy, or do endoscopy retrieval. Here you may do endoscopy retrieval along with dilatation. Surgery is required in a small number of patients. The seventh statement, I think there's one more. Capsule endoscopy is useful to assess post-operative recurrence of Crohn's disease after or as an alternate to fecal calprotectin, small intestinal ultrasound, or MRE. In fact, if you look at these 2 studies, and this is a meta-analysis, which found capsule endoscopy to be as good as MRE and ultrasound. Excellent accuracy, AUC. Majority of them, when you evaluate small bowel, are turned out to be Crohn's disease. So impact of these findings on the outcome of surgery for ulcerative colitis, suspected ulcerative colitis, has not been demonstrated. Now, use of bowel preparation, simethicone is recommended before capsule endoscopy. I'm not sure whether we should include this statement, because this is a general statement overall. This is not for specifically for Crohn's disease. But if you have to evaluate Crohn's disease, now it is well mentioned that you must do a good bowel preparation. And people have used PEG in various doses. And they have found that visualization is improved by the odds ratio of 3.13 and diagnostic yield is increased by 1.68. And addition of simethicone has been shown to improve the visualization in 2 randomized controlled trials published in the last 10 years. So here we are discussing this forum Crohn's disease, where in 1986, there was an editorial which said Crohn's should not be talked about in India. So how do we go about it? Should we take all these statements one by one again, or? Yes, I can, but I don't have them together, but I'll just skip the slides and show you the statements. Dr. Desai. So I think what I said is that this statement to me is very clear, except that whether we add after indicative ileocolonoscopy or that is not required.
Can we add, in the absence of obstetrics
See, the only issue is that if you look at all the guidelines, and I went through all the guidelines, nobody talks about obstructive symptoms for initial diagnosis. They talk about obstructive symptoms when the established diagnosis comes in. So I don't think we have data to avoid capsule endoscopy for the initial diagnosis of small bowel, looking at whether the obstructive symptoms or no obstructive symptoms. In fact, nobody has bothered about that. Yes.
Will we putting a discussion after every statement? Yes.
I get your point.
Whatever the other guidelines they say, I think maybe in the discussion or in the statement, if there is no contraindication.
In absence of clear-cut features of obstruction. Okay. So my point here was more important was that if you have a suspected Crohn's and your ileocolonoscopy is positive, suggestive of Crohn's, will you still evaluate for the rest of the small bowel in the beginning itself or not? That's the point which is important. No, that's why I've said if it is to be done in all cases, then I'll remove after negative ileocolonoscopy. I'll say it should be done in all cases, irrespective of positive or negative ileocolonoscopy.
What does the evidence say? Because in my personal opinion, to define the extent of the disease is a prerequisite for any disease.
Let's hear others.
A small bowel evaluation should be a part of it.
So if you look at the evidence, nobody has really looked it into in great details. So either we can just leave it at that, and in the discussion it can come that for mapping you may do in spite of the positive ileocolonoscopy, for mapping of the disease.
For mapping, actually, in suspected disease, the dilemma is between whether to do a capsule or a MRE. So it has been shown that the diagnostic yield is almost similar, but in capsule endoscopy detects more proximal disease sometimes. But actually, the clinical relevance of this more proximal involvement is still unknown.
That particular MRI that you talk about, that's actually a very high quality MRI because to pick up small abscess ulcerations or anything, most of the best centers in our country, they are not even.
But sometimes we need to see the extramural involvement also.
No,
extramural involvement.
Fair enough, but mucosal involvement is a problem.
So here we are talking about, primarily about the diagnosis. So I think my own feeling is that we should talk about after a negative ileocolonoscopy and leave it at that. But we can come in the discussion.
You need a cross-section imaging. You need always do a cross-section imaging. And that should be mandated according to me. That's what I think everybody practices. Either a CT or a MRI. And that will tell us. And capsule endoscopy should come only after that.
I agree. I think a cross-sectional imaging can be done before capsule endoscopy.
That should be.
But if there is
For the suspicion of Crohn's disease, I don't agree at all. I don't agree at all. See, you will miss if you are looking at a small bowel disease and you depend on isolated small bowel disease. No, Rupa, I'm sorry, but I disagree again that for suspected Crohn's disease, all literature, meta-analysis has said that all patients do not require MRE because the risk of so here we are talking about suspected. See, there are two things we are talking about. One, we are talking about evidence, and one, we are talking of expert opinion. What we are discussing here is expert opinion. Evidence says that for the first diagnosis of suspected small bowel Crohn's disease, if you have done an ileocolonoscopy and you are still suspecting small intestinal disease, the next investigation is Crohn's disease. Capsule endoscopy. Nobody talks about MRE being diagnostic for Crohn's disease of the small bowel as the initial investigation, because you will miss a lot of proximal small intestinal disease and what Ajay said is correct, in spite of the best of MRE. So what you are trying, Rupa, is that we do first ileocolonoscopy, then we do MRE, and then we do, if still suspicion is there, then we do a capsule endoscopy. Evidence is not in favor of that. Evidence is not in favor of that. Yeah, this is the first statement. Please show the statement slide.
So this will be the last comment. So we have 9 statements.
No, if we see so this is for the diagnosis. Still you are not diagnosed. The patient comes to you and you have a suspicion of Crohn's disease. You do the ileocolonoscopy, it is negative. So for the diagnostic purpose, this statement is only for the diagnosis.
Yes, agreed.
It is not for the extent of disease. It is only for diagnosis. So can MRI alone diagnose in a negative ileocolonoscopy as a Crohn's disease?
In fact, what Mahesh showed in his own data, MRI incremental value of capsule over MR dermatography was only 10%. So a cross-sectional imaging and Crohn's is a transmural disease. We are not looking at only mucosa. So I think we need to have one assessment which gives us transmural.
The question is only for diagnosis.
Diagnosis of Crohn's not only done from mucosal, it can also be done from transmural involvement. Long segment transmural.
You can be diagnosed in the absence of histology. Yes, I think that is where the whole issue is.
So,
You have isolated small bowel growths beyond the reach of your colonoscope. Then you keep histology. Your capsule may show some lesions, your MR may show some lesions. So, the practicing algorithm is that you demonstrate where the lesion is and go and biopsy.
Ajay, sorry, Naresh, there is an issue there. Now, first of all, endoscopy has come only in the last 10 years or 15 years. Second thing is that even if you do a biopsy, majority of the time biopsies are non-conclusive because you're taking a superficial mucosal biopsies in most of the time. So I think biopsy is not mandatory for diagnosing small bowel Crohn's disease. So what I showed you in my second statement, that this combined with other features or with biomarkers is the standard criteria for diagnosis in absence of history of NSAID in the last 1 month. No, but you don't have a biopsy proof. Yes, Dr. Desai.
I have one issue that I wanted to raise. See, what we talk about on the page is L4 clause. Small bowel involvement in colon is a disturbance. Some radioactivity. We can hear you. We can hear you. So what we talk about is L4 clause disease. Now L4 clause disease distinctly as compared to the garden variety disease. Second, isolated L4 disease or combined with L1 plus L4, L3 plus L4. So we already would have lesions. So here we're talking about a very small subset of patients who have got isolated L4 disease in which capsule endoscopy has a point. For the garden variety of this thing, we would not be needed.
So what I'm suggesting is that
7% is the L4 involvement. Usme se isolated L4 is और भी कम है.
So what I am suggesting, see, we cannot get away from this statement. Capsule endoscopy is indicated in to diagnose suspected small bowel Crohn's disease after a negative ileocolonoscopy. I think I will persist with that. We are initial diagnosis. I don't think MRE can replace capsule endoscopy.
Whatever the debate is taking place in the overall context that where you fit it. If you look at the statement, the statement is no problem. And only one can add in the discussion that any obvious evidence of tuberculosis or contradiction should be ruled out. So the statement is clear.
All right, so
It is an option.
look,
Can I just let us stop here? In principle, the first statement is okay. Whether to add negative ileocolonoscopy, we can discuss it later. Let's move on to the second statement.
second statement is that it's not very specific. What Naresh was trying to say, that capsule endoscopy finding in small bowel Crohn's disease should be interpreted in correlation with other features to differentiate from similar appearing lesions such as tuberculosis, NSAID, and many more. So I think this statement is important. And so I'm not going to the details of this. The third statement was scoring system as CA may be useful to determine the predictability and severity of disease, somewhat akin to the conventional endoscopy scoring. I don't think there is any problem in this. But this is not as per the ECO guidelines. ECO guideline doesn't mention this, but I thought we have enough data to include this. Now, a cross-sectional imaging or a patency capsule should be done prior to capsule endoscopy in suspected stricturing Crohn's disease. No, this is important because now we are talking of suspected stricturing Crohn's disease.
I think this is important, sir, because when general people practicing gastroenterologists and
This is not specific to IBD.
Yeah,
This
but-
is something which is suspected to every capsule endoscopy.
yeah, but I think
So why should
But-
we have any IBD question? That's not.
No, see,
I have no objection to the statement.
no, I think Ajay, this is important because when we talk of Crohn's disease, we are talking about 20-30% being stricturing Crohn's disease. So it's a small but important group. Secondly, people do not have a concept of patency capsule. And if we do not bring that somewhere in a discussion, then that important topic is not discussed at all. All right. I think let's leave it to the. All right. So this whether it will be a statement or part of a discussion, let them decide later on. Now, number 5 was in patient, this is important, I think this we need to mention. In patient with established Crohn's disease, capsule endoscopy gives a lot of information, but is not a first preferred choice over cross-sectional imaging due to risk of capsule retention. I think there should be no problem in this. Though we know that in remission, prediction and all, it is very useful, but there is always a risk of capsule retention. Retained capsule can be retrieved. So this is again a very simple answer. This is there in ECO guidelines and most of the guidelines. So I thought we must mention something about it, but leave it to, because again the retrieval by endoscopy is something which has become more and more useful in the last 10 to 15.
So we can actually include that as part of the discussion in the previous statement.
Yeah, all right. I think these are important statements. Let them decide depending on the number of statements. But these information should go in the paper. Yes.
The statement of retrieval of capsule indicate that all capsule needs to be retrieved. Or we say if the obstructive symptoms develop, like retained capsule can be retrieved with the device-assisted endoscopy with or without balloon. Surgery is only warranted if endoscopy fails.
See that now the definition of retained capsule is very clear. Anything which is beyond 14 days is retained capsule. So whether you should remove in all cases or not, it's not clear, because we also know that there's a risk of perforation, there's a risk of bleeding, there's a risk of obstruction. So I think there's nobody has studied the natural history of retained capsule. Yeah, here it is saying that 85% are asymptomatic, but it's at a particular point. Nobody has seen what happens to these 85% over a period of time.
When we say the patient is symptomatic, then you can remove it.
I think that should be included again in the discussion part. We should not mention that in the statement.
We got 3 statements for diagnosis and we got 7 for capsule. I think that's not.
So I think that needs to be controlled by that. But I think in the ECO guideline, including the recent one, there are about 8 statements on capsule endoscopy. So capsule is important. Okay, the next one was capsule endoscopy is useful to assess postoperative recurrence of Crohn's disease after or as an alternative to fecal calprotectin, ultrasound or MRE. Of ultrasound, whether you're talking of MRE, there it can be combined that these are the 4 modalities which can be used rather than stressing on capsule endoscopy here. Yeah, so this can be a combination when we are talking of the various modalities. And no, that's fine after negative ileocolonoscopy. See, again, everything is for a small bowel here. We are talking about small bowel. Agreed. Those caveats will always be there. But then Dr. Puri, we cannot get away from the evidence. And what I'm talking about today is not my expertise, but I'm talking about whatever evidence I have seen in the last 15 years of review of the last 15 days of review of the literature. Now, capsule endoscopy is indicated before planning surgery in patient with indeterminate or unclassified IBD. Now, again, this is now well established that if you have 10% of the patients who have colonic involvement, but you're not sure because of mixed features, before you operate on them, a small bowel evaluation by Crohn's capsule is indicated. And the last one was about preparation. I think preparation, we may not talk about preparation. Nagi? We should or we should not? Capsule endoscopy preparation. I think we should not, because this is common to any bowel.
Before we write it as an introduction,
So this can be when you are talking of suspected in the first statement, it can be in the discussion that for optimum capsule endoscopy finding, preparation should be done. That's when you are writing about first statement. Thank you.
So that was a very crisp review by Dr. Goenka. I don't know where he gets time from. All right. So let's go to enteroscopy. So thank you for the invitation. And approximately 2/3 of the patient with Crohn's disease will have small bowel involvement, and many of them have terminal ileal involvement as well. But 1/3 will have inflammation exclusively in ileum, and this inflamed segment may be out of reach of colonoscope. Enteroscopy, the role is it usually after colonoscopy, upper GI endoscopy, imaging, and capsule endoscopy. So let us just quickly review the evolution of enteroscopy. Initially it started with push enteroscopy with pediatric colonoscope. Then the separate long push enteroscope came. Then there was push enteroscopy with variable stiffness scope. But there was realization after this that with overtube one can achieve more depth of insertion. So we had double balloon, single balloon, through the scope balloon catheter, and then spiral endoscopy and motorized spiral endoscope. So similar in single balloon, double balloon, but larger in the power spiral enteroscopy. The instrument channel again now it is about 3.2 and even more in the recent scope which are short. This is important, the overtube diameter 13.2, 13.2, but much larger in the motorized spiral endoscope, and the total working length is about 200 centimeter and shorter in power spiral. So let's go on to the first statement. So the first statement is device-assisted enteroscopy in the form of balloon-assisted enteroscopy, that is single or double balloon, or a motorized spiral enteroscopy can be used for suspected or known Crohn's disease, and I have added little whenever available. So let's see. So we know that in patients with suspected Crohn's disease, enteroscopy is indicated for confirmation of suspected diagnosis of Crohn's disease based on cross-sectional imaging or capsule endoscopy. And as Dr. Goenka said, it is important to rule out alternative diagnosis as mentioned here, and also to get histological diagnosis, although we know that the yield is low. And here there are multiple studies, more than 11 prospective and retrospective studies. And these one can achieve the diagnosis of Crohn's disease in 25 to 75%. And in established CD, the diagnosis of active CD, which is suspected on imaging or capsule endoscopy, and this can manage this can alter the medical management. So nearly 1/3 of the patients who have abnormal video capsule endoscopic finding had normal double balloon results, and 1/4 with abnormal capsule endoscopy had different lesions. So we need to confirm these. There may be active disease in the small bowel, although colonic lesions may have healed, which is known, and this may be relevant for de-escalating therapy like infliximab. Also, we need to decide about the choice of therapy, like in case of stricture, whether the stricture is suitable for balloon dilatation or surgery, and the treatment of bleeding lesion, and of course, as discussed, removal of impacted capsule. So when there is a difficulty in patients with IBDU and we want to be sure, one of the investigation after capsule would be enteroscopy. So the diagnostic yield of device-assisted enteroscopy in established Crohn's disease is much more, 77 to 100%, and this is based on multiple prospective as well as retrospective studies. And this have been in pediatric as well as adult, and they had significant impact of management, as I showed. The failure rate, that is to reach the target area, is up to 17%, and the complication rate is 1%. So this is the statement. Device-assisted enteroscopy in form of balloon-assisted enteroscopy, that is single or double balloon, or novel motorized spiral enteroscopy can be used for suspected or known Crohn's disease. I have added when available, but the host can decide. And here the evidence is from cohort studies, and there is a fair evidence. So I have made this as 2(2)B. We will come to this later. The next statement is novel motorized enteroscopy and balloon-assisted enteroscopy have a similar overall yield in suspected Crohn's disease. So we know that both device-assisted enteroscopy and NMAC are effective for enteroscopy in Crohn's disease. The yield for device-assisted enteroscopy in Crohn's disease, as I have mentioned earlier, is 25 to 75%. And earlier studies have studies with individual devices, then there have been RCTs between single balloon and double balloon, and which indicated that the depth of insertion was more with double balloon enteroscopy. Now we have a recent RCT from AIG, and this is a randomized control trial. This is single balloon enteroscopy versus novel motorized spiral endoscopy, and 177 patients with suspected Crohn's disease underwent 201 endoscopies. The technical success was similar, but technical success for antegrade was much more with the motorized spiral endoscopy. Diagnostic yield, however, was similar, and the procedure time was much less with spiral endoscopy. Depth of insertion was more, and total enteroscopy also were more with motorized spiral endoscopy. So both NMAC and small single balloon enteroscopy were safe and effective for small bowel evaluation in suspected Crohn's disease. NMAC scores or single balloon with regards to deeper small bowel evaluation with complete small bowel coverage and shorter procedure time. Both had impact in management in more than 90% of the patient, and adverse effects were mild and no perforations in either group. The cost we need to know. There was another study, double balloon enteroscopy versus motorized spiral endoscopy. This was an interesting study, case match study. That means 31 patients who had undergone motorized spiral endoscopy recently were compared with 62 patients who underwent double balloon enteroscopy between 2014 to 2022. So much longer period. And they were matched for various things. And the primary outcome was to compare technical and diagnostic success rate between double balloon and motorized spiral endoscopy. And the main indications were suspected GI bleeding and positive radiological finding, and 71% were antegrade. And we can see here that the technical success, the diagnostic success and therapeutic success were similar. However, there were more complications with motorized spiral enteroscopy, and there were 2 esophageal lacerations which needed hospitalization and ileal perforation. So the complications of device-assisted enteroscopy include perforation, bleeding, pancreatitis, overall 1%. A large Japanese studies with 29,000 diagnostic balloon-assisted endoscopy reported 32 cases of perforation. The perforation rates were higher in Crohn's disease, 2.5 to 8.6%. After balloon dilatation, 0 to 10%, and bleeding was 2.5%. So the statement is, novel motorized enteroscopy and balloon-assisted enteroscopy have similar overall yield in suspected Crohn's disease. So there is evidence here, and this is randomized trial, so it becomes 1, and there is a fair evidence to recommend this action. So B, because there is only 1 trial, so we will come to the discussion later. Then the third. Which one? Okay. We are doing it, but it was the initial. All right, then it will come down. Okay, good. I thought they were random. Okay, thanks. Yes. Yes. So, yes, this was bidirectional. So complete, that's why total enteroscopy. Okay. So the next statement is balloon-assisted enteroscopy does not require general anesthesia and can be done under propofol sedation. So this is more of a common practice than a statement. So I didn't really find any evidence. There is a AIG review on anesthesia in 2015, but it does not specify procedures and sedation required, so I don't know whether we keep it. We keep it as a practice.
Whether we should include this
This is a general statement for spiral. Balloon does not require, it's not specific to IBD.
Yeah.
I don't think the statement should be.
So we can say that in practice, how do we do it? Okay, so balloon-assisted enteroscopy is preferred over NMAC in post-operative and pediatric cases. So here I have taken pediatric population first, and DA is feasible in children more than 3 years old and with a body weight of more than 14 kg. This is Dr. Rupa Banerjee's review, and thank you for that because it made my work much easier. So we see this here, pediatric cases. So total cases here are 56. This is in suspected Crohn's disease, and here this was in established Crohn's disease. So 38 patient. Another series also has showed that. So NMAC in AIG study, there were 19 patients, and the technical success was reasonable. Only thing is, NMAC cases, the average age was 16 years, and small bowel enteroscopy, lowest age was 7 years. So we really can't draw any comment for the pediatric age group for NMAC. So here we can say that balloon-assisted enteroscopy is preferred over motorized spiral enteroscopy in pediatric cases. Still further evidence is available. Yeah. So, shall we finish and then come, or? Okay. All right. Then we'll come back to this. So, next statement is motorized spiral endoscopy enables deep, rapid, deeper and complete small bowel examination, and it is advantageous in situation requiring deep small bowel intubation like distal jejunum or proximal ileum, and when complete enteroscopy is required. So, let us take the first statement. So, this is the first statement. Okay, so we know now from AIG study and the earlier studies that definitely deeper intubation and faster enteroscopy is possible with NMAC. So there is a evidence from the trial. So here for this statement we have evidence that is 2, and whether it is A or B we will discuss subsequently. So in the next statement is NMAC should be used in caution in post-operative cases, and there is very little data on pediatric patients. So there is a recent report on spiral enteroscopy in post-operative patient, and these included GI as well as non-GI. This is 2021 paper, and their aim was to see the diagnostic ill and adverse event following in spiral endoscopy, including patients with major abdominal surgery. And there were 74 antegrade and 62 retrograde in 172 patients, and of these 50 were having prior abdominal surgery. And if you compare all the patients, there was a technical success was good, diagnostic yield was good, and depth of maximal insertion also was good. Sorry, 1 minute. I'll come to that. I'm coming to that. Okay. So in the patients had prior surgery, the insertion time was slightly more, which was significant. Diagnostic yield was similar, and adverse events were minor at 10.3. Now we are coming to prior GI surgery. Okay. This is where we are saying, of course, not Crohn's disease, but significant number had Crohn's disease. So here there was lower maximum depth of insertion in patients who had prior GI surgery, 189 centimeter versus 374 centimeter, and the insertion time also was similar. So it was safe. Although there was a longer procedure time and lower depth of maximum insertion. So this pediatric I already discussed. We need more data for this. So we'll come to this later. So this one is the device-assisted enteroscopy can be used for management of stricture in the form of balloon dilatation and stricturotomy. So we have a review and meta-analysis. 18 studies with more than 1,000 patients. Technical success rate was 95% with a low complication rate. The short-term clinical efficacy was 83%, and on follow-up, 1/3 of the patient needed surgery. The complication rates were in this study, this was actually dedicated to endoscopic balloon dilatation, 73 studies, 1,800 patients, 2,340 procedures, perforation rate in Crohn's disease, 0.12%, and it was similar for all indications. And for therapeutic balloon assisted endoscopy, it was 1.7%. And the dilatation was attempted in 207 patients, and 30% needed surgery in 18 months follow-up. So 1/3 of the patients needed surgery. So, okay, so I'll come to the statement now, and we can discuss those. Okay, so device-assisted enteroscopy in the form of balloon or motorized spiral can be used for suspected known small bowel disease. Any? Yeah, we can remove. It was in AIG study, so I kept it. Okay, fair enough. Agreed.
Sir, I think when available should be removed.
Huh?
When available should be removed.
But that was my addition, so we are free to remove it.
Which subgroup are you advising?
Okay, so we can add that. The statement was that it can be used, and we have discussed the situation when can. So in the paragraph below, we can say that, okay, these are the indications that we will use it. All right. My main issue was that it is not; these are not available universally. That's.
Availability is not for the state. Available.
All right. Okay. So, should we say can be considered or should be?
Is useful.
Okay.
Device-assisted endoscopy in the form of balloon or spiral endoscopy is useful for or can be used.
Is useful.
Is useful.
In what context is it useful?
Useful in the diagnosis of
Assessment
suspected.
or therapy of small bowel.
That should be added.
So, in principle, if the sentence is okay, then the grammar we will adjust. All right. That therapeutic has come later, that's why. I think this statement there is adequate evidence. Novel motorized, so motorized enteroscopy and balloon assisted enteroscopy have similar overall yield. Yes. We can add in the discussion.
The reason is, if you have found ulcers proximally, you can go another 100 centimeters after the ticket.
Then why do it? Why do it? Why do spinals when you can have it only?
So he said,
Martha has a study. How we should go this slide.
I'll just show the slides. Level of evidence. So this is the graphical abstract of our paper. So as you can see, the overall diagnostic yield was similar because most of the lesions in suspected Crohn's were in distal ileum also. That's why the overall diagnostic yield was similar. But when we did subgroup analysis of those who are there in the distal jejunum and proximal ileum, the yield was more with motorized spiral enteroscopy. So that's the point I want to highlight.
But that's not a paper as yet, so we have no evidence, we can't take that as a...
No, sir, already published, sir.
Can I ask you a question on motorized endoscopy further? Because a lot of these patients with Crohn's disease have high deficiency anemia. How many of them do you have problems getting across and dilating? Because this is something that we have.
So in known Crohn's disease, we have not done much of motorized spiral enteroscopy. Only for suspected.
Here they are suspected, they have high deficiency anemia.
Yeah.
They do, a lot of them have webs and things like that, it's difficult to get through. So how much are these?
We routinely dilate all those patients.
All patients. If you still have problem, you have a lot of laceration, you have not.
Yeah, those superficial mucosal injuries were almost seen in almost 1/4 of the patients throughout the GI tract. But when we consider the ASD lexicon for adverse events, the moderate to severe adverse events are similar between them. None of the complications required hospitalization.
These lacerations in the upper esophagus and the throat, they just disappear.
So should we write similar E or should we write?
So,
So endoscopy in IBD, we thought we will have one section.
I think my own suggestion is that even for this statement, when you are saying equal yield, in the discussion it can be
Yes.
that for pediatric population, we should not make, because there are so many other issues in pediatric.
So I was thinking that we should have one, at the end we should have one section. We take from these statements only and create one for the pediatric population guidelines. That generally this is preferred and
See, in this one has got some general states. Either we should move or two, I think two are sufficient. And in that discussion we can, because even this statement is not necessary to be added.
So-
we agree from this side, other statement.
yeah, so basically what Dr. Matthew is saying that we can add a separate paragraph for pediatric. All right, done.
Actually, there are a lot of studies, almost 12 studies in pediatric suspected Crohn's disease.
Take my.
Small meeting can be done with the pediatrician.
So what
I
that,
think we can do a subgroup. We
Yeah.
can take opinion from a pediatric panel and add it that we added these in the panel.
Yeah.
So I think that is how we go.
so this is a straightforward statement. I don't think we need any further comment on that, but if there are any comments, please. No. It has come in the AIG study.
Rupa, sorry, David, just a quick thing.
Huh.
All these statements are related to the technique.
Yes.
So therefore, we should be concentrating on its utility in IBD. The rest of the technique can be put in the discussions.
No, this is in IBD only. This is in IBD only. And
This is occult GI, IBD or any other disease. NMSC will be having further deeper.
no, this one is in IBD, suspected Crohn's.
Is that we have already discussed spiral versus monument.
Yes.
Here itself, these are more of a information about the
the technique.
So this can come in the discussion
on that in that same statement.
So here's the point. In fact, all the stem of your statement should start with IBD or CD. And the techniques and other things should follow, I mean, if at all they're applicable. So primarily this is the evidence in favor of a technique for evaluation of this one.
I think that is a point well taken, that we should all have, the main statements will all start with something related to IBD, and in the discussion part we can add technique and we can add other comments, other problems.
All of these are in IBD only, but your point is well taken that, okay, this is what.
We have to have something in what kind of Crohn's disease. So we can take a call on that.
All right. Because here there was a clear-cut data. Anyway, so okay, post-operative cases, there is little evidence, and we can, rather than a heading, we can add this as a subheading. This should come. DAE can be used for management of strictures in the form of CRE and all. I think. No, stricturotomy, there is very little evidence. Balloon dilatation. Yes. No, there are reports of stricturotomy. आपका ये review है वो? Okay, thank you.
So I think we go on to the next.
So good morning, everyone. My talk, what has been assigned, is association of clinical and inflammatory markers with small bowel endoscopy. So the outline of my talk would be, I would be just touching base on the clinical indices, the inflammatory biomarkers and endoscopic tools, which we have already discussed. And my main task is to weave a pattern between the clinical indices, inflammatory biomarkers, and the endoscopic disease activity. So as we had heard in the beginning, Crohn's disease activity index as of today is positioned as the gold standard. But we know that there are, although it is very useful, but there are certain problems associated with it, which could be the retrospective nature, the subjectivity, and it needs an ideal body weight. And because of these, many other indices, they attracted attention. And of this, the Harvey-Bradshaw Index, which is something similar, but it is a simplified CDAI, was taken up, and it shows a good correlation amongst both of them. For the pediatric population, we have the PCDAI, and we have the weighted or the average PCDAI. As far as biomarkers are concerned, there could be the serum biomarkers, the fecal biomarkers, the novel biomarkers, which includes the cytokines, the microRNAs, the metabolomics, which in future may project or help us in identifying with accuracy the diagnosis, the follow-up, as well as in suspected people, the screening as a screening tool. Endoscopy, we've had great discussion since morning. We know about ileocolonoscopy and its limitations of cost, its limitation of invasiveness, the frequency when required, as well as the risks and the associated discomfort, the patient discomfort, which frequently is reported as those related to preparation. And the newer non-invasive techniques which have come up have already been discussed in detail. We had a session about the endoscopic disease activity indices. The CDAIS, because of its complexity, it is not frequently used, and what has been adopted is a simple endoscopic score for Crohn's disease, SES-CD. And as far as the capsule endoscopy is concerned, we have the capsule endoscopy CD activity index and the Lewis score. So once my talk is to knit all of them together. So when we talk about correlation between the clinical indices and the endoscopic indices, we see that there is discordance between the CDAI and the mucosal inflammation, both with ileocolonoscopy as well as with the capsule endoscopy. And this could possibly or probably be related to the subjectivity, heavy reliance on symptoms. And another factor which I would like to specify, in one of the studies, the reliability of CDI was itself questioned. In that study, a large number of patients with IBS, they had higher scores as compared to Crohn's disease. More so in patients who have no inflammation on endoscopy, other symptoms unassociated should always be kept once a person is complaining of increased frequency of stools. The other issues which need to be looked into are the intestinal dysmotility, malabsorption, SIBO, IBS overlaps, infections, symptom overinterpretation. So clinical symptoms as scored by CDI are not reliable measure for the underlying inflammation. We had a recent study where pooled data from 3 trials was taken from adalimumab, Upada, and Risanki, and it was shown that there was a moderate correlation between CDAI and week 12 and 16 simple endoscopic score for Crohn's disease. But these correlates were stronger for colonic disease as compared to the ileum. Recently, we have attention from the patient-related outcomes, and the 2-item and the 3-item patient-related outcomes, which includes the symptom frequency, the pain abdomen, and the third one being general well-being, is also said to correlate well with CDI and the symptom endoscopic score, simple endoscopic score. A weak correlation between Harvey-Bradshaw index and the Lewis score on capsule endoscopy, and HBI could not even discriminate between inactive and any form of severe disease or mild disease with the capsule endoscopy. In children with newly diagnosed Crohn's disease, the weighted PCDI correlated poorly with the endoscopic disease activity. So summarizing, clinical markers should not be used in isolation to determine the disease activity. Going on to the biomarkers, if we look into the CRP is a very commonly used biomarker for IBD, although it is non-specific. If you look into the association with disease activity, if the CRP is increased, there is active lesions on the endoscopy. If the CRP is normal, there are studies which still show that there is mild inflammation, and the mild inflammation has been shown in as high as 90% of the cases. So if you interpret it in a clinically active Crohn's disease patient, if CRP is normal, it rules out severe endoscopic inflammation. The other point which I would like to point out, 15% of the healthy population and 20 to 25% of the Crohn's disease patients, they do not have a CRP response. And this is related to the genetic polymorphisms and gives a false negative test. As a single marker, CRP has insufficient accuracy to predict mucosal healing. 30 studies, the CRP ranged between 4.4 to 28 milligram per liter, with a median sensitivity of just 79.5 and specificity of just 61%. In another study again, CDI and CRP underestimated the endoscopic activity by the Lewis score in patients with Poisson disease. In pediatric population, correlation between Lewis score and PCDI and CRP was moderate, whereas correlation in the adult population between LS, HBI, and CRP was weak. So a better correlation of LS with PCDI and CRP is seen in the pediatric population. As far as post-op recurrence is concerned, there is conflicting data which is available. There is no consistent association which has been confirmed between endoscopy and CRP 54 weeks after surgery. And in that study, highly sensitive CRP was considered, it was thought that it may be a better marker to be assessed in post-operative recurrence as compared to the normal CRP, what we consider. In the similar study, the area under the ROC curve to discriminate between patients in endoscopic remission and recurrence was 0.86 for fecal calprotectin and 0.70 for highly sensitive CRP. So this shows that fecal calprotectin as well as highly sensitive CRP could be used as markers to look for post-operative recurrence prior to going in for endoscopy examination. Again, in a study by Schofer et al., it was seen that the calprotectin had the highest, closest relation to the simple endoscopic score for Crohn's disease, followed by CRP, blood leukocytes, and CDA. And it was the only non-invasive marker which was able to discriminate from mild, moderate, and highly active endoscopic disease. In another study, it was seen that both fecal calprotectin as well as fecal lactoferrin correlated strongly with the Lewis score for capsule endoscopy and predicted relapse. Nevertheless, there are studies, on the other hand, which show a weak correlation between the Harvey-Bradshaw index as well as fecal calprotectin as well as the endoscopic lesions. Fecal calprotectin has been shown to have good relationship with the colonic CD as well as ulcerative colitis, but it is less sensitive and specific with the small intestinal Crohn's disease. It shows a good association with mucosal healing in Crohn's disease, and the cutoff levels which have been seen are as vary from 71 to 918 microgram per gram. But once we look at FCP and histological activity, identifying the cutoff, again we need larger data. As was discussed by Dr. Goenka in his first slide, FCP could be used as a selection tool, and it has a good probability to identify patients where capsule endoscopy could be carried out in suspected Crohn's disease patients with negative ileocolonoscopy. Of recent, there are various combination of markers which have been tried. We know about high neutrophil lymphocyte ratio, which has said to be having an increased correlation with clinical disease activity, but not with your endoscopic activity. We are all aware about the pivotal CALM trial, which was used as a first trial for treat to target, and the post-hoc analysis has shown that fecal calprotectin plus CRP plus clinical response is better for mucosal healing outcome. The other index which has been identified and has said to have more predictable value or relation with the endoscopic activity is the Utrecht Activity Index, not very popular, not very frequently used, but a simple daily stool frequency, CRP, FCP, platelet count, and NPV, which are the factors which are associated. So just summarizing the evidence what we have today, clinical indices, there is discordance between the CDI, between HBI and the endoscopic indices, be it with CDAIS or the Lewis score or the capsule endoscopic Crohn's disease activity index. PRO2, the patient-related outcomes, the two-item stool frequency and abdominal pain said to correlate moderately with the simple endoscopic score for Crohn's disease. If you look at the inflammatory markers, CRP is the most widely used. It is association with disease activity, insufficient to predict mucosal healing. HS-CRP, highly sensitive CRP, may predict post-operative recurrence, and correlation with Lewis score is better in the pediatric Crohn's disease. Similarly, for fecal calprotectin, it is the strongest evidence as a single biomarker, and it is useful to rule out as a selection tool, which I mentioned previously. It is used for mucosal healing purposes. It can be used to assess the disease activity, and it predicts the post-operative recurrence. The statements which Dr. Rupa sent were these two statements. They are as such, seromarkers, including ASCA, can be used as an adjunct for confirming small bowel Crohn's disease in cases with non-specific biopsies for terminal ileitis.
I think we need comments on the second statement. The first statement is, of course, accepted. But any role of biomarkers, because biopsies, as Dr. Goenka said, that will always be non-specific. In that case, should be.
So is ACA. So is ACA.
So should we just say that as of now, that
there is no role for biomarkers?
We can remove this statement with ASCA. The other point of fecal calprotectin and HSCRP, I think we need to separate out these two and give two statements and make its role prominent as to where they are active as the data is available.
Statement goes up. Second statement can go up. What was the level of evidence for that?
We have to have that monitor shoot and test it.
Moreover, that will carry on the same.
Yes, so is that
doing
more
that,
health thing also should be added as a statement or just in the discussion?
you can type discussion, this may not.
The second statement, you can keep say that there is no evidence to say.
No, because this has been a point of discussion. So you say that, against that statement, you say that there is no evidence. It can be the main thing, but you say that negative. After all, we are not only going to include statements which are supported by evidence, we are also including statements which come up as thoughts, but we can say that there is no evidence.
Sir, I think there is a dichotomy between Indian and non-Indian studies. So if you take that into consideration, better to avoid area where there is confusion. Because we cannot be very dogmatic that that kind of statement is not useful at all. It can apply across board. So certainly in India we would not use it. So it's better not to put such a statement.
No, rather than avoid this statement and be ambiguous, you can always say that more evidence is needed. Say more evidence, there is limited evidence, more evidence is needed, that's all.
We can also say there's geographical variation.
But it should be there because
In India, this was used mainly to differentiate between tuberculosis versus Crohn's. So that is on that. And ASCA was actually, but in genetic studies, they have tried to interpret using ASCA to whether they should be taken up or then to evaluate.
You don't agree with it? No, you don't agree with this statement, but whatever it is, you have an objection to including this statement and be characterized
I
as.
think the controversy is that GM wants this to be mentioned the negative.
Yeah, that's.
Whereas others are saying that we just include this. Yeah, so others are saying that I think let's do that.
sorry, but in endoscopy and IBD, where does this fit?
We also have to have
I think we will remove that thing, like what someone is saying, actually, just remove it.
I think we'll
Consider it.
We'll discuss that and discuss the context of it. So I think thank you, Dr. We should, thank you, David. So we'll go on to the
we
next.
put on this, the settings.
Has been made simple by Dr. Vandana, highlighting the role of markers in Crohn's disease as not very effective in assessing mucosal healing. So I'll just restrict myself to assessment of response. When should we repeat endoscopy? So this is in that limited set of patients who have ulcerative colitis of Crohn's disease. We have started therapy, and then when should we go in and repeat a colonoscopy or an endoscopy? So all these statements which I'm making are based on literature review from this as well as the literatures which they have quoted to, and I will not allude to each of the literature on each of the slides. So the response, why we assess response, how do we assess response, when do we assess response, what is the criteria for response, and what is the final endoscopy target. So this is what we are going to discuss. Why we assess response? Because if you assess response and the patient has good response, it confirms the diagnosis and helps in prognostication. Second is, if the patient has partial response, that is the time to check for compliance and escalate therapy if required. If there is no response, we may have to change our diagnosis or change our treatment strategy. So assessing response is important. How do we assess? We have clinical criteria. We have laboratory criteria, radiological criteria, endoscopic criteria, and histological criteria. Histology is actually the final gold standard. As it was alluded to earlier on also, you may have endoscopic healing, but yet histological healing may still elude you in that sense. Among the clinical criteria, what is practically used in ulcerative colitis is the partial Mayo, and for Crohn's disease, it's still the CDAI. In laboratory criteria, CRP and calprotectin are our two cornerstones. ESR is hardly of use in follow-up of patients. ESR may be useful only with the true love widths in the acute severe ulcerative colitis. MRI or ultrasound are emerging tools, but they are not so well validated for long-term response, except MRI has a role in assessing transmural involvement in Crohn's disease. So diffusion-weighted MRI has shown promise in assessing response in Crohn's disease. For endoscopy, we have Mayo scores or SES-CD. So these are the two standard scores we use. Dr. Sood had alluded to how UCEIS is better than the Mayo, and I agree with him that if we have to use an endoscopy scoring method, UCEIS is better, especially in research settings. So as we go on from clinical to histology, the specificity goes up, but the feasibility goes down. So as an initial assessment, we should use clinical and laboratory with or without radiology, and then if in the next set, we should be using endoscopy and histology. And whenever we do endoscopy, we should do histology, because even if there is endoscopic remission, you may not have clinical remission, a histological remission. And the other thing which has been shown, which Dr. Vandana also alluded to, is a combination of clinical CRP and calprotectin. This combination is the best combination we have in clinically and biochemically assessing patients for ongoing disease activity. Clinical criteria, there are several studies. I'll allude to this one, the PRO2 study, where it has shown that the patient-related outcome, that is in the form of stool frequency and presence or absence of blood, these two are vital in ulcerative colitis. Addition of pain becomes important in Crohn's colitis. What has been shown is that in ulcerative colitis, this clinical criteria of absence of blood and normalization of stool frequency is a good surrogate to presence of endoscopic remission. So that has a rho value of 0.9, p-value of 0.001. So clinically, if the patient is not in remission, there is no point trying to look for endoscopic remission. That is very important for us to take home from here. First thing is clinical response. Second is laboratory response. Only if these two things has happened, then actually there is no point doing endoscopy in ulcerative colitis to assess for clinical response. The story is slightly different in Crohn's. In Crohn's, these markers, clinical markers, are not very good because the symptoms are non-specific. It can indicate something else, and the rho value you can see is 0.3. It is not significant. So in Crohn's disease, clinical symptoms are not the best guide to tell us whether endoscopic healing has happened or not. In UC, it is a good guide. So there are standard criteria of in UC response is defined as 3-point reduction in the Mayo score or a 30% reduction in Mayo score. But the bleeding subscore should be either 0 or 1. And in remission, the Mayo should be less than 3 with no subscore more than 1. In laboratory, what do we have? As I said, we have 3 things: fecal calprotectin, CRP, and ESR. And as I said, ESR has limited utility. Fecal calprotectin, our target value should be somewhere less than 150. If it is less than 150, it's more likely to be associated with endoscopic remission. More than 150, more likely to be active. You can repeat the calprotectin after a month. So 2 consecutive calprotectin reading less than 150 tells you that the patient is most likely in endoscopic remission. And when you know that he is most likely in endoscopic remission, there is no role of repeating an endoscopy. CRP is a useful guide, especially in Crohn's disease. Also in ulcerative colitis, more useful in the acute severe UC. In Crohn's, it is useful in the chronic management of these patients also. So lower the CRP value, the better it is. And ESR, as I said, has limited utility. So what are the indications for repeat endoscopy in IBD? First is to assess response to therapy. This is what was the this was a statement. I will qualify this as we go on. But definitely when there is no response, when there is a flare or a relapse, you should repeat an endoscopy to document the flare, document the relapse, and if there is non-response, you have to look for other causes, maybe inadequate therapy or some other diagnosis. So whenever there is an indication for alternate therapy or surgery, you're planning to start biologicals, you're planning to send the patient for surgery, that is the time again an endoscopy should be repeated. And the next is when you are planning to de-escalate therapy, that time you have to document that the patient is actually in endoscopic remission. So at any time before you are planning de-escalation, you should repeat an endoscopy. And the other indication is mucosal healing. There has been a paradigm change in the way we have looked at IBD. Initially it was patient response and then symptom response, then all these calprotectin response. But what is the final touch point for us or target for all of us is mucosal healing. So, and also as I said, when you're suspecting an alternative diagnosis, when a new symptom comes up or a patient you're treating like Crohn's disease, patient starts developing fever and has lymph nodes here and there and you want to rule out tuberculosis, or in a patient with ulcerative colitis who now comes with a stricture, you want to look for malignancy, at that point of time you should repeat an endoscopy. So what is mucosal healing? By the STRIDE 2 consensus, mucosal healing is our long-term target to be achieved in patients, and it has been defined by IBD group as in UC, absence of friability, erosions, ulcers in all the examined segments of the gut mucosa. So to say mucosal healing, you have to do a full ileocolonoscopy. Just doing a sigmoidoscopy will not help. In CD, again, absence of all visible ulcers in all the visualized segments of the gut mucosa. So that is our target. There is criteria which are all standardized criteria: Mayo's endoscopic score of less than equal to 1, or UCIS of less than equal to 1, and SES CD of less than equal to 2, and CDEIS of less than 4. So the targets for treatment in STRIDE consensus is any patient with acute severe, any patient with active IBD, you start treatment according to the risk stratification which we discussed yesterday. You assess for symptom response. Symptom response in ulcerative colitis in the form of stool frequency and blood. And if that symptom response has happened, then the next thing you're looking for symptom remission, that the symptom should become non-existent in the terms of blood and stool frequency, and the CRP should normalize. So this is our second target. So first target was symptom response, second is symptom remission with normalization of CRP. Only after we have done that, and then you document calprotectin. So serially what happens is first there is symptom response, then symptom remission, then CRP normalizes, then there is reduction of calprotectin. So calprotectin is the last thing to go. And after that, you have to document endoscopic healing, and you should not try and document endoscopic healing till you have got 2 normal calprotectin values. So these are the short-term targets, these are the intermediate targets, and these are the long-term targets according to the STRIDE 2 consensus. So there are several benefits for mucosal healing. All that I would say is it results in 4 times higher chance of long-term remission, colectomy-free survival, long-term mucosal healing, long-term corticosteroid-free survival, as well as lesser risk for malignancy, lesser risk for hospitalization, surgery, better quality of life, and less penetrating complications. So there is no doubt that that should become our new goalpost. So defining healing in IBD, the patient's perspective is he should be able to carry out day-to-day activity without support. That means normal stool frequency. And yes. Yes, sir. Yeah, sure. No worries at all. So endoscopic perspective, we should have mucosal healing. Pathologist perspective, you should have complete histological remission. And if there is, so how do we assess in a patient with IBD? You start treatment. If there is no clinical response, then you look for active disease. And you have to step up therapy or look for infections or optimize dose. If there is clinical response, document that the calprotectin is okay and then do an endoscopy to pick up endoscopic healing. There's only one study which has, yesterday this question arose that in patients with clinical remission, is there any role of endoscopy? Actually, there is no role. The overall consensus is no. But however, this study from Italy has shown that amongst those who had endoscopic remission, they had lesser relapse rates compared to those who did not have endoscopic remission. So this is a statement by ECO which says in patients with UC who clinically responded to medical therapy, mucosal healing should be determined endoscopically or by fecal calprotectin. Note the word or. Approximately 3 to 6 months after treatment initiation. I'll come to this timing. Endoscopy should be taken as a reference standard for assessment, and flexible sigmoidoscopy is adequate in UC and colonoscopy in CD. So earlier on, we used to look for endoscopic response. Now there is no we should use endoscopy only for assessing endoscopy healing. So when do we repeat? Is it a time bound or a patient oriented thing? It should go by patient oriented, that means response based and not time bound, not 3 months or 6 months. It should depend on every individual patient when we should be doing, because response guided thing is found to be better, more cost effective, patient friendly, avoids unnecessary instrumentation, and we know that symptoms are a good guide in UC. However, in Crohn's disease, we still should be doing it time bound. So this is 2 interesting slides. I'll just take 30 seconds on that. All that I would want to say is that clinical response in 5-ASA is at 4 weeks. In oral steroid, it is at 2 weeks. At infliximab, it is at about 5 weeks. Tofacitinib about 6 weeks. Vido at about 9, and thiopurines at about 11. So all the drugs have different time to clinical response. So when are you going to assess is an issue. So repeating endoscopy before you expect a therapeutic response may not be rational. And assessment of mucosal healing again is very different for different drugs. So I have proposed here putting things together. 5-ASA and steroid, by 4 weeks we will get clinical response. For the biologicals, except for Vido, we will get it by about 6 weeks. For TOFA, again 6 weeks. Thiopurine will take about 10 to 12 weeks. So if we assess all of them at about 12 weeks, that is a good time to assess. So clinical response assessment at 12 weeks is a good time point. For mucosal healing, we use, again, things are again different. So 5-ASA and oral steroids by about 12 weeks mucosal healing, biologicals by about 16 weeks, and thiopurines by about 24 weeks. So if you want a single time point to assess, we should use not earlier than 6 months. However, as I said, it should be only after patient has shown clinical response with normalization of calprotectin. So as an algorithmic approach, patient of IBD on treatment, first look for clinical response. If there is clinical response, look for fecal calprotectin and CRP. If they are normal, now our target is to assess for mucosal healing. If there is persistent elevated fecal calprotectin and CRP, there is no point doing endoscopy. You wait with increased therapy or escalate therapy. If there is no clinical response, then you should go in and do an endoscopy, because when there's associated elevated calprotectin or CRP, you may want to step up therapy, change therapy, rule out actions. So that is a time when you need to do an endoscopy. Dr. Saurabh had already covered this. All that I would say, there's only one study which has shown that at 9 days in ASUC, if you repeat endoscopy, it can help in prognostication. So these are the statements. Response to therapy in active ulcerative colitis should be assessed at 12 weeks by a combination of clinical assessment, CRP and fecal calprotectin. Routine endoscopy to assess endoscopic response in patients with UC is not required. However, in CD, it is different. In patients with active CD, response should be assessed at 12 weeks by combination of clinical assessment, CRP and fecal calprotectin. Endoscopy and or radiology assessment should be performed within 6 months, because the other parameters are not sufficient indicator of mucosal healing. Then the other two statements are in patients who have evidence of...
This discussion will be taken up later.
Sure, sir.
All the images.
Sure, I'll leave it. Okay, thank you.
So, next we will move on to the next lecture, which will be by
Okay, so I'll be dealing with the topic of post-op recurrence in Crohn's disease. What should be the scoring methodology and what should be the timing of assessing this recurrence? So starting with the baseline, the risk of surgery in Crohn's disease, as we all know, as the disease progresses over a period of time, almost 50% of the patients at the end of 10 years will require some form of surgical resection or surgical induction of remission. Now, once that surgery has been done, the surgery as of now is not considered to be curative in Crohn's disease, and post-op recurrence in almost all patients where surgery is done, the recurrence is considered to be the norm. Now, recurrence generally will occur at the site of anastomosis after bowel resection in the following sequence: that the endoscopic recurrence occurs first, which precedes the clinical recurrence, and then finally there is a surgical recurrence in a subset of the patients. So the natural history of Crohn's even after surgery is that the phenotype of the baseline disease will follow after surgery invariably in a large percentage of patients. So what does the evidence say? In almost multiple pivotal studies, it has been shown that as soon as 1 week, there are histological changes in the mucosa even after surgery. At 1 year, endoscopic recurrence will occur in around 70% patients. At 3 to 5 years, 30% to 60% of the patients will have clinical recurrence. So now this endoscopic recurrence number is very high as compared to the clinical recurrence, and recurrence, whenever it is happening, is clinically silent. At the end of 5 to 10 years, almost 50% of the patients who underwent a surgery earlier will require a repeat surgical procedure. Now, there are multiple risk factors in which patients the recurrence will be earlier, which will definitely be there. But this is important for the risk stratification, slightly out of this context of today's talk. So let me just start with that. How do we predict this post-op recurrence of Crohn's? Now, this pivotal study came from Professor Rudgreet's group, which was in 1990, wherein they prospectively followed up around 89 patients who underwent an ileal resection for Crohn's disease, and recurrent lesions were observed endoscopically in the neoterminal ileum within 1 year of surgery in 73% of the patients. But out of these 73, only 20% patients had symptoms, and 3 years after surgery, the endoscopic recurrence rate had increased to 85%, and symptomatic recurrence happened only in 34%. Now, based on this study, they proposed a score which we are still using, which is called the Rudgreet score. And it's a fairly easy score which we use in clinical practice, that in a post-op patient with an anastomotic site, we try to score the lesions, the recurrent lesions, in terms of I0 to I4. I0 meaning the ileal mucosa, the neoterminal ileum does not show any recurrent lesions. I1 means that there are only aphthae and it is less than 5 in number. I2 means that there are more than 5 aphthous ulcers with normal mucosa in between them, or larger ulcers with scaparias, or there are aphthae or ulcers at the ileocolonic anastomotic site. I3 is a more diffuse disease which still remain aphthae with diffuse ileitis, and diffuse inflammation with deeper ulcers, nodularity or stenosis is I4. So this was the basic Rudgreet score. Now, what does this score signify? This signified that I0 or I1, that is less than 5 aphthae in neoterminal ileum, the clinical recurrence happened in less than 10% patients, whereas if the score was I3 or I4, more than 90% of the patients had a recurrence at 5 to 10 years. Hence, the baseline study took I0 and I1 as remission. I2, I3, I4 were taken as disease recurrence. Now, the score was designed to predict clinical recurrence in Crohn's disease, and again, in the pivotal publication, the I2 subcategory included aphthous ulcers both in the terminal ileum as well as at the ileocolonic anastomotic site, which was a heterogeneous, had a heterogeneous risk. Now, because there is a school of thought that the anastomotic ulcers are suspected to be post-surgical ischemic ulcers and hence are less predictive of progressive disease, a modified Rudgreet score has been proposed in literature. So, what is the modified Rudgreet scores? The rest of the score remains same, but the I2 subcategory is subdivided into 2 categories. In I2A, which says that the lesions are only confined to the ileocolonic anastomosis, and I2B, which says that the lesions are there in the neoterminal ileum with normal intervening mucosa, whether or not a patient still has anastomotic lesions. So now we have 2 more categories. Now, the question is the subclassification of Rudgreets into I2A and I2B clinically significant? So we have a lot of literature based on this. So there are again 2 schools of thought. The first part is this study. So this was a cohort study which included all post-op CD patients, and disease activity was assessed using a modified Rudgreet score. I2B disease here was found that is associated with significant endoscopic progression compared to I0, I1 or I2A disease. That means this study found out in a retrospective manner that if patients had lesions in neo-terminal ileum, the disease progression over a period of time was more significant. So another thing which they found was that I2B progressed earlier than I0 and I1 lesions. So their inference was that post-op ileal disease recurrence, not the isolated anastomotic inflammation, confers increased risk for severe endoscopic disease progression. Now, the previous one was a retrospective cohort. Now, there was a large prospective cohort study, which was the REMIND study, which came in 2020. Now, this was a prospective multi-center study. Again, here the ileocolonoscopy was done at 6 months after surgery. Now, an endoscopic score was, was proposed by this study, which said that we should be scoring anastomotic lesions separately and the ileal lesions separately. So they gave something called as a REMIND score, which is shown there, but the basic premises remain the same, that they wanted anastomotic and the neo-terminal ileal lesions to be scored differently. Now, here it was seen that the clinical recurrence-free survival was significantly shorter in patients who had ileal lesions at early post-op endoscopy, whatever their severity was. Now, this was irrespective of whether a patient had anastomotic lesions or not. So anyone who even had the baseline, the primary ileal lesions, was supposed to have a severe disease later on. Now, coming to the second aspect of it. Now, there have been studies which have found contradictory results. Like in this study, the rate of clinical post-op reference was not found to be different between I2A and I2B. So that means that the therapeutic strategy could be left alone in I2 subcategory as such. Now, there is a corollary which comes out from such data. The previous studies were showing I2B to be more aggressive lesions, whereas this study shows that I2A, that means aphthay present at the anastomotic site, are not innocuous and cannot be ignored. So there was a meta-analysis which was published last month comparing all the studies, and this meta-analysis also suggested that the same treatment strategy should be applied to all patients who are classified as I2 on the Rutgers score. That means we cannot ignore I2A as only innocuous lesions. Now, again, this begs the question that should we be modifying the Rutgers score at all? Now, as of now, the optical clinical management with the isolated anastomotic ulcers remains unknown. Though less, there is suggestion that the risk with even with the isolated anastomotic ulcers is not negligible. And there is some data to say that these patients will progress on to disease. The second aspect of my talk was when to do an colonoscopic assessment for assessment of disease. 6 months after the surgery is the most common time which most of the studies in literature have reported. Now, why 6 months? Because most patients, around 70 to 90% of the patients, will have an endoscopic recurrence by 1 year post-op, which is considered to be too late in practice. Now, some prospective studies have also observed that lesions were already present at 6 months after surgery in most of the patients who went on to develop the post-op recurrence at 1 year. Now, why to monitor? So, there are two aspects again here, that if we detect disease early and if the patient is not on any post-op medical prophylaxis, then it gives us a chance to start that post-op prophylaxis. And secondly, if the patient is already on post-op prophylaxis, we can step up the medical therapy. And there is very good evidence coming from a randomized trial which came in 2016 in Lancet, which is the POSTER trial, which I'll take a minute just to highlight. So, what is the timing? What do the guidelines say? So, AGA 2017 guidelines mention the timeline to be ideal, we should be repeating between 6 to 12 months. The Spanish working group suggested 6 to 12 months. ECO guideline says 6 to 12 months. Now, there are no guidelines or data to suggest what should be the further frequency of a subsequent colonoscopy after you have done the first colonoscopy. And various studies have followed 12 to 18 months interval for doing subsequent colonoscopies. So, just briefly about POSER trial. So, this was a multicentric randomized trial wherein 174 patients were included and they were randomized between active care and standard care. Yeah, 30 seconds, sir. I'll just finish this. So herein, all the patients who underwent a surgery, they received 3 months of metronidazole. There was risk stratified in low risk and high risk. And low risk, no treatment was offered. High risk, thiopurines were offered. And if the patient was thiopurine intolerant, they were also given adalimumab. Now, they were randomized into 2 groups, no endoscopy or endoscopic intervention. And at 6 months, when the endoscopy was done and the treatment was intensified, it was seen that the overall difference was around 18% in the outcomes. So that means doing an endoscopy or a colonoscopic assessment of recurrence and intensifying therapy had a great clinical significance on the overall recurrence rates. I think I would like to stop here, and these were the statements which we can discuss later. Now? Sure. Okay, thank you.
For the next talk.
So, at the outset, express my gratitude to Team AIG. For want of time, I'm going to focus my talk only on pouchitis and cophitis. So 1978, landmark study in the BMJ, which changed the perspective for patients who had refractory ulcerative colitis and FAP. The technique of ileal pouch anal anastomosis, or IPA, or J pouch was described, and by Parks and Nichols, and many of you in the audience would know that Parks is the same person who had the Parks classification for perianal fistulae. Subsequently, there was the Me Too attitude, so S pouches and W pouches came, but they could not stand the test of time, and the J pouch is the standard of care. And the reason for that is that it has a low rate of post-operative morbidity. For some unknown reasons, obviously related to the immune activation, J pouch, pouchitis is more common in IBD versus FAP, and the post-operative complication rate can be anywhere between 5 to 35%. As with all surgical procedures, the J pouch is associated with complications, and these are being classified into inflammatory, which includes cophitis and pouchitis. And this is what is the focus of my talk. I'm not discussing structural leaks and strictures and neoplastic. So by definition, pouchitis is inflammation of the pouch, which typically presents with diarrhea and urgency. Mind you, I have not put over here, and it is not a manifestation. You don't get bloody diarrhea when you have pouchitis. You only have a diarrhea, which is just at best traces of blood. And if you have frank bloody diarrhea, that would suggest cophitis. And the clinical presentation is classified into acute, which is less than 4 weeks, or chronic. So for the diagnosis of pouchitis, 2 criteria must be fulfilled. So first is the patient has to have symptoms. So symptoms, as I said, would be essentially diarrhea and the tenesmus, urgency, etc. And there has to be endoscopic inflammation. And if both are fulfilled, then we make a diagnosis of pouchitis. Here, histology plays a supportive role. Sometimes they come up with an unusual diagnosis, which I'll be discussing later. If you don't have, so there are symptoms without endoscopic inflammation, that makes it IPS, which is a twin of IBS. And here the histology has a confirmatory role, because if the histologist tells you that there's absolutely normal ileal mucosa, then you are confident in making a diagnosis of IPS. But it's all a matter of perspective. You know, if you tell a giraffe to take a picture or paint a picture of a lady wearing a large hat, then this is what he's going to paint. So from a perspective point, let's talk about the surgical perspective. The surgical perspective is the J pouch. I think one must know the anatomy. Hence I put there, know the anatomy, and this is more for the people who have just started their careers. So this is the afferent loop that you can see. This is the pouch inlet. This is the tip. The tip is on the efferent loop, and the apex is here. So the apex and tip are... So the apex and the tip are at two opposite ends. So afferent loop, efferent loop, the length of this is supposed to be anywhere from 15 to 20 centimeters, and a good pouch should have a capacity of about 250 ml. From the endoscopist perspective, what we see is the typical owl eye appearance. And some of you would know that I have a flair for bird photography, and this is what it looks like. So this is, the owls are beautiful to photograph. And these are the two eyes of the owl, and this is the ridge in between. This is, I think, my carry-home slide. So if you take a look at this, let's start with this. So in classical pouchitis, the one that you get due to the immune-mediated injury, you can see the afferent limb and the efferent limb are both involved. In pouchitis associated with PSC, afferent limb is involved, efferent limb is involved, and the terminal ileum, neo-TI, is also involved. So that is it. But look at this. So if you have involvement of only afferent loop, efferent loop is spared, then that is typical of ischemic pouchitis. This is referred to as asymmetric pouchitis. These both will be symmetric, symmetry referring to whether both afferent and efferent or not. And if only the cuff is involved, then we call it cuffitis. This is a typical picture of a PSC-related pouchitis, angry-looking mucosa, and at least all the 5 features can be seen here. There's erythema, there's friability, granularity, exudates, and ulcerations. I put this slide intentionally because especially I think this is being broadcast. The people who are starting their careers should know how to write a pouchoscopy report. So you start with the extent, you write afferent limb, efferent limb, involved, not involved, neo-TI, involved, not involved. And then you talk about the distribution, which I just mentioned. It could be symmetric or asymmetric. Then you talk about the severity. Is it focal lesions, diffuse involvement? And then you go into the descriptive details, hyperemia, ulceration, granularity, etc. If you're doing a research protocol, somebody's doing a thesis, then you might be adding PDAI, which is the activity index score. And then finally, you mention the site of the biopsy and make sure that you put the bottle for the afferent loop and the efferent loop cannot be same, different bottles. What is the role of the histologist? The role of the histologist is basically to confirm the presence or absence of pouch inflammation. If it is no pouch inflammation, that's IPS. And most importantly, give a definitive diagnosis in conditions such as CMV, neoplasia, or so secondary causes are important. CMV, as I mentioned, NSAID enteropathy. C. difficile, you don't make a histological diagnosis, that is a toxin assay. I did mention about the PDAI, 3 criteria, each one is scored. So if you add, total should be more than 7, only then you say justified in calling it pouchitis. Coming to the cuffitis, in the same diagram, you can see that there is a cuff over here. The length of this cuff is anywhere between 2 to 4 centimeters. When that gets inflamed, then you call it cuffitis. Typically, it presents with a bloody diarrhea. Pouchitis, non-bloody diarrhea, and best managed with 5-ASA local, may require systemic. For diagnosis of cuffitis, you require a biopsy from the cuff. That's important. So endoscopic inflammation and histological inflammation are necessary to take it. Cuffitis, 3 different phenotypes. Corticosteroid 5-ASA responsive, corticosteroid 5-ASA dependent, and finally corticosteroid 5-ASA refractory. No talk on the pouch can be complete without a mention of Crohn's disease of the pouch. The standard definition, as the standard abbreviation for that is CDP. So I'm going to be talking about CDP, just 2 slides. The diagnosis of Crohn's disease of the pouch is based on clinical features, endoscopic features, imaging. All of these can be non-specific except histology. And this is classified, Crohn's disease of the pouch is classified, can be inflammatory, stricturing, and fistulizing. Now I'll just run through the slides. So this is a typical CDP, Crohn's disease of the pouch. You can see both sides of the pouches involved. They are discrete ulcers and there is normal intervening mucosa. For those interested, I think they can refer to the atlas, the article by Beauchamp, extensive pictures of the pouch, but just briefly to say, the typical features of CDP or Crohn's disease of the pouch is discrete ulcers with normal intervening mucosa. You can see a large discrete ulcers, strictures in the afferent loop, symmetric involvement of both the loops, and pre-pouch ileitis, that is in the neo-terminal ileum. So this is finally my position statements. Do you want me to take it now or shall I take it in the end? Whichever way you want it. I finished on time. Okay, sir. So the statements are: endoscopy with biopsy should be performed in assessment of pouch-related symptoms. I don't think there's any argument of that. Pouchoscopy report I put there, which you hadn't put. So I've said pouchoscopy report should include status of both the limbs and the neo-terminal ileum. This can be combined, 2 and 3 can be combined, that asymmetric inflammation suggests ischemic pouchitis, and specifically sites of the biopsy in different bottles is afferent loop, efferent loop, and neo-terminal ileum. And the role of histology I've added is only to exclude a diagnosis of secondary pouchitis.
See, I think at least in the description we should write that biopsies, even if you take biopsy from the normal looking area.
No, from the pouch. And if they are discrete ulcers, then there is no need to take a biopsy from the normal.
And the patient has got pouch symptoms, but you don't see any ulcers. Where do you take biopsy? Because we know that we have differentiate between.
If there are no symptom, if the patient has symptoms, no lesion, then it's just a random biopsy, and you expect that the histologist is going to say that it's going to be normal, and that makes it IPS.
No specific sites that we should take now.
No. If there is no specific lesion, no ulcer, then you just take a random biopsy and prove that there is no inflammation, that to make a diagnosis of IPS. Yeah. Yes. Now, I think with the statement that Rupa sent me was that you take a biopsy from the tip of the pouch. I reviewed the literature. There is no advantage at all in taking a biopsy from the tip of the pouch. If you're suspecting a leak, then its radiology is going to help you. It's not endoscopy that is going to document a leak. I can't understand if two of you speak. Huh?
What I'm trying to say is, it should be right. When you're mentioning that it should be reporting the status, when we're writing biopsy site, should not include the tip of.
No, you don't have to take specifically from the.
Development of Crohn's disease, that is the first site to be.
No, that's not the first site. If at anything would be a, Yeah. So I don't think the tip has any advantage at all. Yes, the cuff, if you're suspecting cuffitis, then you take, that picture is entirely different because only that small 2, 3, 4 centimeters segment would tell you that that is inflamed and both the limbs of the pouch will be spared. So in that case, you can take biopsy from afferent loop and the cuff. You don't have to take... Yeah.
Point number 2, in that, I think in the end you should add the cuff.
Yes,
Okay?
agreed.
The third statement can probably be a discussion.
Yes, agreed.
I think
I think if everything is okay, we can probably close down and move forward.
Okay.
Sorry, yes, our statements, I think, on we shall discuss it.
So we had a few other statements. I'll airdrop. Airdrop.
You already shared, na, sir?
No.
No, sir.
Coming.
Dr. Usha, would you like to come on stage and just defend the statements quickly so that the time is...
Yeah, might have received, sir.
Session 2. Session 3.
Because you have the slide. You can tell from here, that will save us a lot of time. First statement was response to therapy in active ulcerative colitis should be assessed at 12 weeks by combination of clinical assessment, CRP and fecal calprotectin. Routine endoscopy to assess endoscopic response in patients with UC is not required. So this was the statement one.
This change.
Changed it because Dr. Rupa told me that I
Okay.
can change it.
So slides.
It's not.
Final Pondicherry.
This one, madam?
You took it. It's here.
The same one. This is the file.
Yeah, so this was the statement, Dr. Vishal. So do we have any inputs from the house where we can modify anything? Sorry? Any therapy, whatever therapy you're planning for the patient. Sir, we are looking for mucosal healing after we have got clinical response and calprotectin normalization, CRP normalization. Only then we look for mucosal healing. Sir, that is the next statement here. Here it is. Let me read up all the 4 statements so that...
I just wanted to ask you, what is the meaning of routine endoscopy to assess ER, endoscopic response? What is routine endoscopy?
We can drop the word routine. We can just say endoscopy not required.
We can write clinical response to therapy in active ulcerative colitis.
Yes,
Should be assessed at 12 weeks. Clinical response.
Dr. Ajay?
Actually, sir, clinical response has also always been combined with CRP and calprotectin. As a combination, they work better than just clinical response.
No, the question is 12 weeks versus 6 months. So what you are assessing at 12 weeks? But response means you are doing, you have advised 2 things. One is at 12 weeks, one is at 6 months. So 12-week response, we have to mention what kind of response we are looking at.
So
Yeah,
6
so we have
months
to
is...
address this.
Let me clarify again. Ulcerative colitis, you first assess clinical response. The best time to assess, as I said, for different drugs is at different time, but a good single time point is at about 3 months.
At 3 months, you assess clinical symptom score, you assess for CRP and calprotectin. If the patient is fine at that point of time, there is clinical response, you repeat a calprotectin, and if 2 calprotectin, consecutive calprotectins are normal, then the patient becomes a candidate for assessing for mucosal healing. That ideally with most of the drugs comes around 6 months. So you assess response at 3 months. In UC, there is no need for doing a colonoscopy. But at 6 months, when you want to assess mucosal healing, that time colonoscopy is required. For Crohn's disease, at 3 months, you should be assessing clinical, biochemical, and if required, an associated endoscopic assessment, because in Crohn's disease, the clinical parameters do not correlate very well with mucosal healing.
That's mucosal, you mean is endoscopic remission, right?
Yes, ma'am.
There is some evidence of disease activity, then what would you advise?
Then that means you don't still have histological healing. You should push the therapy towards histological healing. Yeah.
He's saying, no, endoscopic healing and
Yeah.
histology is not the same.
Yeah, so any patient at 6 months, if you find endoscopic findings, though the patient is clinically well, calprotectin is fine, then you know your target is endoscopic healing followed by histological healing. So you have to push the patient towards those 2 targets. Sir, in the group which has shown clinical response, clinically they have responded and calprotectin has normalized. In them, our target becomes endoscopic healing. That may happen depending on your, even with biologicals is only in 30% patients at 6 months. So you may not get complete endoscopic mucosal healing. So
Sir, that is the response. Now we have to aim both things. I mean, endoscopy's purpose and purpose of PRO, patient-related outcomes, and biomarkers and endoscopy. All 3 we are trying to look at the 2 things, response and remission. We may not really use the term mucosal healing at this time. What we say is the clinical remission, which includes all 3, symptomatic, biomarker, and endoscopic healing. So, I mean, if we are looking for clinical response also, as what Sir is saying, there is a partial response. So, I mean, that is the purpose of repeat colonoscopy, which I think that we have been discussing should be more response-guided rather than time-bound. If we can just say something like this, then we avoid committing to either 12 weeks or 24 weeks.
yeah, I agree with you. That is why here...
Ma'am, in that statement, from 6 months you can correct it to 24 weeks, because in one parameter you are speaking about 6 weeks. I mean, sorry, 12 weeks.
24 weeks.
Yeah, 24 weeks.
Okay. So here again, I think I'll try to incorporate Dr. Sood's statement on this, that response to therapy should be assessed. I'll take out the time point here by a combination of clinical assessment, CRP and fecal calprotectin. Endoscopy is not required.
I think the first part is not needed at all. What we are going to do is when should we repeat colonoscopy? If the patient is in remission, do we really repeat at 3 months? We will not.
No.
So,
Dr. Usha.
We will not repeat.
what sir is saying, what I would agree with what sir is saying. Sir, if you can repeat it once again.
Like there are, in clinical practice, we have to go by PRO and biomarkers. But we need to document that, yes, because our treatment target is not just absence of symptoms. So we want to ensure that there is a healing, otherwise we need to change the treatment. I mean, up to this, I think there is agreement.
Sir, can I say something?
We may not agree on histological remission, but if there is no endoscopic remission, then we need to make some changes.
Sir, can I say something?
Sure.
So we have to document endoscopic healing. As per STRIDE 2 also, we can document in form of endoscopic response, which is not synonymous with endoscopic healing. So if there is a decrease in the subscore of Mayo or SES-CD, that can be taken as an endoscopic response at an appropriate time, and endoscopic healing remains a target to be achieved. So that means if a patient is on therapy and if the subscores are decreasing at, say, a particular timeline, that means that the patient is responding and we need not be pushing up the therapy at that point of time.
I think
to say we don't go for endoscopy.
Yes, Dr. Jayawant.
See, what Ajit was talking, I'm just extending it further. When you are managing a patient, you're looking at a clinical response, clinical remission, fair enough. And of course, you're looking at a biochemical. In your statement, you're looking at a biochemical as well. When it comes to looking at a endoscopic remission, I mean, that we understand that's okay. You have put a third statement. Do we need to include this line in the first statement that endoscopy to assess response in patients and with use is not required? I said it's not required, and why should we put it there? It is confusing. But the reason I'm saying it is not required because it is confusing to the layman who will read that endoscopy is not required at all. Because in the next statement it will say that you repeat it after 6 months.
Dr. Ajay?
One second.
Can you be brief because we're running out of time? One more.
Dr. Palli, problem is that I was raising hand right from the beginning. It's a free for all for everybody. That's the problem. Anyway, carry on.
Sir, in a nutshell, I'll work on the statements and improve upon it. In a nutshell, you do not use endoscopy to assess endoscopic response. You use endoscopy to assess only mucosal healing or endoscopic remission. So you're not using endoscopy to assess response to therapy. That is the paradigm change.
Can you just give a draft statement on which both of you can then work together? And because what you said actually is exactly what Dr. Sood said, that if you can just give a statement, we'll just note it.
I want to add one more thing, that in a patients who are not showing clinical response, have we included that in the, I don't find that, maybe I missed that. Those who do not show clinical response, will you repeat colonoscopy in those patients?
Yeah, I think that should be the statement. And
here it is there. Na? Endoscopic reassessment is required to assess any relapse, refractoriness to therapy, fresh unexplained symptoms, change in strategy, stopping or de-escalation of therapy is planned in patients with IBD. So these are all the situations where you have to do an endoscopy.
There might be one more situation, Usha, where you have discordance. The patient is, PRO is showing improvement, but your CalPro still remains high. What would you do in that case? If there is discordance between the inflammatory markers and the PRO?
Yeah, so then that means that if CRP or calprotectin is high, that means the patient has not gone into, has not shown response. So
No, but the patient is saying, I'm passing 2 stools a day, I'm having Bristol 4, I'm fine, his hemoglobin is fine. Then what will you do?
So then that patient,
will you ignore the inflammatory markers?
no, you should do. That is the time when your patient is having some refractoriness to therapy. Clinical, there is a discordance. At that time, you should do
That is the clinical
No, that
response
way,
on
Usha,
biochemical.
sorry. In that way, if biomarkers are still high, we should delay the procedure. We should not do colonoscopy. It can be the other way around.
Going beyond the time, I think we should close down.
Okay, thank you.
Sumit, yes, come forward.
Summarize, because time 1:30, half an hour.
yeah, I think Dr. Usha's statements are very important. And as Sumit prepares the slides, I think by the end of the day, we'll have 2-3 slides ready for Dr. Usha's statements. Because Sumit will just show one slide from Sumit.
Because you're a half an hour behind.
Yeah, for Dr. Sumit's will not take much time, but
Okay. So these were the consensus statements of the draft statements I modified. So for assessing disease activity in the post-op Crohn's disease, Rudgate score at an anastomotic site and new terminal ileum should be used to assess severity of recurrence. This has been the standard across all studies. Okay. Now, the only...
this can be in the discussion.
Yes, the next 2 statements can be in the discussion and we can give the relevant literature along with that. Now, the second draft statement was the colonoscopy should be performed The statement given to me was within 1 year. I have refined it to 6 to 12 months, ideally 6 months, in post-op Crohn's patients for assessing recurrence. So for that, colonoscopy is not. In literature, it is very clear.
So we only say endoscopy rather than mentioning one. It may be an enteroscopy, it may be a spiral, it may be a colonoscopy. Endoscopic assessment.
Dr. Puri, when we talk about post-op recurrence and whatever data and literature I have reviewed is only for the patients who have a ileocecal or a distal ileal disease. Rudgeats will not apply to any of the mid-small bowel or any other resection or a higher small bowel resection. So this will apply only to this particular garden variety of Crohn's rather than anything else.
So if we look at the published RCT, then that is very clear that it is actually supposed to be 6 months. So why? I mean,
yeah.
if
So most studies, the most meta-analysis and everything says 6 months. But if you look at the guidelines, they talk about 6 to 12 months.
if we were to make
yes,
an
12 months is-
evidence-based statement, then the evidence is for 6 months.
6 months.
Very clear evidence.
And there is a clinical justification because at 12 months, anyways, we have missed the bus because most of the patients will have an endoscopic recurrence by that time.
What is
So,
small bowel recurrence?
so Dr. Goenka's statements regarding capsule endoscopy and the fecal calprotectin statements will actually come into post-op recurrence in isolated small bowel diseases. There is literature in these guidelines on that as well. And this last statement we can keep or we can put it in discussion that there is still no consensus on what should be the subsequent frequency of colonoscopies.
I think discussion.
Okay, thank you.
So I would like to thank all the speakers for the excellent talk.
Individual opinion as well.
Okay, thank you, Team AIG, for inviting me here and helping me learn so many new things. I'm going to address the issue of detecting dysplasia in IBD. We all know the history that we have been taking random biopsies every 10 centimeters of the colon, and in some of these patients, dysplasia was seen and it is termed as invisible dysplasia. 1981, Blackstone coined this term of DALM, where these visible lesions which were seen revealed colorectal cancer. And it was in 2004 that there was an article which brought out the first time that most dysplastic lesions in UC is visible at colonoscopy. So that was a kind of a game changer. And subsequently, there were other articles as well suggesting that colorectal cancer dysplastic lesions were actually endoscopically visible in ulcerative colitis. So these were both from the UK and the US. So we jump from that to the scenic consensus statement, which came out largely from the US group. And what did they say? We need to actually look at the details of the scenic consensus, because otherwise if you just look at just a few main sentences, it can be quite misrepresentative. And unfortunately, they had very little evidence that they could lay their hands on because these things were just coming up. So one of the things that they said was that it's good to use high definition endoscopes, and there was evidence for that. They also said that you needed good quality endoscopy by an endoscopist who's trained for this purpose. Not any endoscopist who can reach the cecum, but someone who's trained to recognize and pick up these lesions. They also said that chromoendoscopy using dyes was superior to white light endoscopy when you use just standard endoscopes. So if you're using standard endoscopes, then you needed to use a dye-based chromoendoscopy. They said if you're looking at detection, NBI and the data provided at that time was not superior to dye-based chromoendoscopy. And they also, of course, brought out this question, document and assess visible lesions, whether it's flat or elevated, the resectable or non-resectable. And they got rid of the term of dysplasia-associated lesions or masses. And they also emphasized that follow-up was essential. So this is really what the scenic guidelines gave us about 7 years ago. So the issues were, first is detecting the lesion. So we need to make this differentiation between detecting a lesion and characterization of lesion. And therefore, NBI and all scored less in detection, because the scopes at that time were not the bright scopes that we see today, but we had the older generation of NBI, and obviously they did not fare well, and hence NBI was pushed down and they pushed up dye-based chromoendoscopy. Of course, when you are characterizing lesions, it's a different thing. So there, of course, there is maybe a role of these other technologies as well. But what are the important caveats? Is ideally there should be no inflammation. Ideally, there should be no post-inflammatory polyps or mucosal tags, which makes it difficult for us to see the surface mucosa. Ideally, you should have an excellent colon preparation, and it should be done by an endoscopist trained in surveillance. And importantly, there should be an adequate time allotted for the procedure, and this is as low as 45 minutes. So you need to have at least that much time if you have to do a good assessment. So this is a kind of lesion that you see can be just a little flat lesion, little irregularity, and then once you see it, then you can characterize it with whatever your image enhancing techniques that you have. Now, if you look at data after the scenic guidelines, you say high definition white light endoscopy. They found that versus dye-based, they found that definitely dye-based chromoendoscopy, this is the earlier data, was 21 versus 9, showed that dye-based chromoendoscopy was superior. And again, there was a bigger study with 150 patients each arm, reported in 2020, showed that compared to high definition white light endoscopy, dye-based chromoendoscopy was superior. If you look like with dye-based chromo versus virtual or NBI or techniques similar to that, they didn't find much of an advantage. Even when they looked at a big network meta-analysis of 18 studies that came out in 2019, they found no advantage of dye-based chromoendoscopy over NBI or like kind of techniques. So therefore, at the end of it, we could summarize that if you do good high definition white light endoscopy, you may pick up as many lesions as with dye-based chromoendoscopy. But if you do not do high definition white light endoscopy, use standard scopes, then you always have to have an additional tool of dye-based chromoendoscopy. So that is the part of detection. As far as characterization is concerned, we know that There are markers of high-grade dysplasia, lesions. This is a study from Sugimoto and his colleagues in Japan. Said lesions left colon, lesions which are flat or superficially elevated lesions or have red color are markers that there may be dysplasia there. What is also important is to see, are the margins clearly visible? That's a very important aspect of when you inspect this mucosa, because only when you have a good margin, then you can think of resection. If you do not have a good margin, then obviously you're going away from any kind of endoscopic therapy. The background mucosa becomes extremely important. Is there a lot of inflammation? Are the lesions likely to be multifocal, and so on and so forth? There are a lot of ulcerations around. Obviously, any kind of interpretation is going to be extremely fallacious. Now, the question is that all of us have been trained with certain kind of classifications and techniques. Can we use the same thing? Can we use Kudo? Can we use NICE or JNET? Or whatever thing to characterize? Unfortunately, not. Unfortunately not. The reason is, unless you have a mucosa that's quite free of inflammation and the patient is in a quiescent phase, then maybe some of those techniques can be useful. Otherwise, if you have a background of inflammation, I don't think the Kudo spit pattern can be used reliably, because inflammation itself produces its changes and the mucosa may look a little more sort of protuberant, a little villiform and things like that, and you obviously cannot use those kind of classifications to make a good decision. So therefore, there is no accepted classification therefore that you can use to predict dysplasia, and that is why the tendency to go and resect more often. People have tried to come up, this is the classification, the facile classification of Frankfurt, where they looked at the morphology, that is the Paris classification, whether it's flat, just raised or depressed. They looked at the surface pattern, vessel pattern, and inflammation within the lesion. And they have come up with some kind of recommendation that this suggests possibly a serrated adenoma or inflammatory pseudopolyps, dysplasia and cancer. Looks very interesting. Unfortunately, no one has validated it. So it's just one study that's come but not been validated. So I don't think we can recommend that anyone follows this. But if you look, even when you recognize a lesion and say, okay, I think this is suspicious, if you biopsy, the yield of neoplasia is only about 20%. So obviously we are overestimating or sort of biopsying more lesions than we would like to, but we have no choice because we are now saying this is some abnormality I recognize, I'm either biopsying or resecting if I can.
Nareshji, one more minute.
Yeah, I'm just. So our random biopsy is irrelevant today. We know that there's data that up to 13% of dysplasias are picked up only at colectomy and missed on colonoscopy. And so one of the recommendations is, i.e. in trained hands may obviate random biopsies, but I don't think it's easy to eliminate it. And most units still do random biopsies, especially in patients where the margin is not well delineated, or there is a background of PSC, or they have a background of dysplasia in the past. So random biopsies, perhaps less, but not totally out. I'm not going to discuss endocytoscopy, confocal, and AI because they may help characterization, but certainly not in the mainstream. So finally, what should we recommend? Certainly good quality endoscopy by trained endoscopists. High definition white light endoscopy should be the norm. You can add on dye-based chromo or virtual chromo for increased pickup and characterization. If standard white light endoscopy is used, dye-based chromo endoscopy must be added on. And if necessary, consider sending to an expert unit. We really want to increase our yield and improve outcomes.
Thanks, Nareshji. Should we use this term VCE? because it stands for video capsule endoscopy, right? So.
Yeah, depend on your viewpoint.
No. All over the world, I think we see
you-
the term is used for capsule endoscopy. So could we modify this? Or?
Yeah, you can. I have not put out the statements. This is just my summary slide. I think Partha has got some statements that we can discuss.
And sir, trained endoscopist means?
Pardon?
Trained endoscopist means trained in
trained
endoscopy or
endoscopist-
for IBD we are trained?
Yes, you need to be trained for surveillance. So if you look at colorectal cancers,
What
right?
we can
People who are
specify.
doing colorectal cancer screening go through a separate training so that
So I just wanted to mention this, that the person who is trained in surveillance of IBD.
Correct. That is what.
Dr. Naresh, why we have
Yes, Matthew.
discussing on dysplasia, Matthew here. It's basically image enhancing endoscopies to identify areas for taking biopsy. Am I right? And so when we actually call patients for surveillance, the previous concept is to take multiple biopsy from segments. So can we replace this image enhancing endoscopy to take biopsy, targeted biopsy? So can we put a statement for that?
Yes. We are still missing patients, but we are up say 85. You don't want to do much of things. They are saying, I am an expert, transmissions, I am an expert. My hands being on high definition endoscopy, I can pick up. So, I should be doing it. But if you're not an expert, you have to do like that. You're not going to do a CIT. If you're not an expert, you do CIT protocol. And that's what
Yeah, I think now the statements have been displayed here. So if you all concur on this, then we'll close. No, this. Oh, also.
correct. I did go into that because I think there's a separate talk on resection and things like that. Yes, but even if you resect, it ultimately goes for histopathology. So whatever is resectable, clear margins, small lesions, up front you can lift and resect. But I thought I would leave it to the session. I think Dr. Puri is going to do that, so I didn't want to step into that area.
I think if we all concur on the first three statements, we will close this and move to the next talk on surveillance. Oh, can't see. Okay, I'll read it for you. The first
Maybe
statement
you can
says,
split the two or put the half there so that.
no, I'll read it for, yeah, we can do that. Otherwise, I can read it dichromo.
Let Gaur finish.
Your last statement, you covered the next topic as well.
Yeah.
Your last statement.
Yeah, okay. So now I'll invite Professor Dr. Gaurdas Chowdhury to speak on colonoscopic surveillance in the Indian context, when and how.
Before lunch, so I'll be brief. Shall we start? Yeah. I'll skip the first two slides. Basically, I'll come to the heart of the talk. Surveillance colonoscopy in IBD. Okay? So, why should we think about doing it? The answer is obvious. It's known to everybody that there's an increased risk of developing colorectal cancer. So, I think there's no debate on that. But if the data needs to be seen, I'll show that to you. And what's the purpose of surveillance? Is that if you detect something early, then the outcome is likely to be better. So if you don't have that, then there's no point in surveillance. So both of them seem to be operative here. So that's the premise. So we go a little further now. The three statements which were given to me by Rupa, these were the three. So surveillance colonoscopy should be performed after 8 years of onset of colitis. That is, when do we start? Okay? Just let it sink in. 8 is the figure here. 10 is what we learnt in textbooks earlier on. So what's the issue? The interval, that is how frequently should you keep doing it, that is annually, 3 yearly, 5 yearly. So that's the second question. We'll go a little bit deeper into that. And the third is that in the Indian setting, do we modify things? What is there in the last, I think all the speakers have alluded to the 6 guidelines. I think more or less my talk is also inclusive of the same 6 guidelines. So what do we do with the Indian data? I see Saurav Kedia here. So their group is the only one I could get the paper my hands on, which have published a little bit on that. So let's take the first question. Should it be, at what time do you say that, look, it's about time that we start doing surveillance colonoscopy? The incidence of CRC in UC varies depending on the duration and extent of the disease. That is all that we know. So longer the duration, more the chances. And this is actually the main slide that you need to see, which says that the incidence goes up after a certain period of time. There's a sharp spike at 10, okay, 10 years. So that's the reason why we all said that, look, 10 years was the earlier figure. These are the precise figures. 7% to 10% at 20 years, 30% at 35 years. That translates to a 0.5 to 1% per year after 8 to 10 years. So mind it, 8 to 10 years, okay? And the cumulative risk of CRC for all UC patients was less than 1% at 10 years. Doesn't quite justify surveillance. And then, gradually it goes to 0.4 to 2% at 15 years and so on and so forth. And patients with extensive UC had a 5-fold increased risk of CRC compared with those who had isolated proctitis or left-sided colitis. So most of it is actually applicable to people with pancolitis, not the ones with limited rectal disease. Okay? I must tell you that at least 2 studies have shown that if you set the target at 10 years, then you tend to miss about 10% of patients who develop CRC, somewhere between 8 and 10 years. So that's the reason why modern guidelines are veering a little bit more towards bringing down the age at which surveillance should be recommended, and that is 8. So that's the whole purpose. These are the recommendations for cancer surveillance in IBD patients. So after 8 to 10 years of colitis, annual or biannual surveillance should be done. Evidence B, finding of high-grade dysplasia and flat mucosa and so on and so forth is an indication for colectomy, and that this is also evidence B. The level of evidence is 3 across. So 3, 3, 3, that's the way it goes. This I have taken from one of the guidelines. So I come to the second statement. So is that okay with all of you? So so if a patient comes to you after 8 years, or if you would say 10 years, that's the issue of debate, which we'll put it up in the statement. I'll come to that. I'll come to that. Just my next slide. Just 1 minute.
Yeah, GC, 8 years of colitis means 8 years of onset of symptoms or 8 years of diagnosis?
8 years from the time of diagnosis. I'll come to the other parts a little bit more. That is, if the person continues to have active disease and, he's a male, so there are few sub-factors which would make you change a little bit. If there's a family history of colorectal cancer, then, the risks get added up. So there you might actually suggest doing it earlier. The other factor that you must keep in mind that inflammatory bowel disease is a disease characterized by remissions and relapses. So if you have been doing colonoscopy anywhere because of clinical indications, you don't have to actually include one more colonoscopy just for the purpose of surveillance. Obviously you have done the colonoscopy for whatever reason. Okay? Now, interval. So should it be annually or should it be at different... Sorry, somebody said something?
No, GC here. So again, the first statement should be super qualify about PSC or
No, no,
other
the
com-
second,
no.
it could be, but I'm just coming to the next one,
Yeah,
the
I know, I
interval
saw
part
this,
of it. So what are the factors which predispose to colorectal cancer? One of them, of course, is the duration of disease, but presence of coexisting PSC. I think Dr. Ajit Sood was referring to this. Male gender, family history of CRC, age at diagnosis of the disease. So younger the age, it's a problem. Severity of inflammation, that is the degree of control, presence of pseudopolyps and backwash ileitis. So these have been found to correlate. Okay. Now, to some extent, there will be flexibility. It doesn't mean that exactly on that calendar year the whole thing starts. I mean, if you feel that there is a need and you want to include a colonoscopy before, probably that's your judgment. I mean, certainly we'll come to the issue of PSC particularly. And these are the colorectal cancer risks stratified for the extent of disease, more or less known to everybody. Pancolitis, more risk; rectal disease, less risk. But this is the slide which I would draw your attention to, which Dr. Sood was referring. So there are high risk factors. Extensive colonic involvement, pancolitis; moderate to severe endoscopy or histologically active inflammation, PSC. PSC is probably the one which has been most studied, that if you have PSC, your chances of risk of developing CRC goes up. You might decide to do it at an earlier stage, the surveillance part, and thereafter when you ask for follow-up, it has to be much more frequent follow-up. So this comes in the category of annual surveillance. Okay? So annual surveillance. Disease commencing at age 15 years, family history of CRC, and presence of a stricture or dysplasia. So if you have any of these, then obviously it is annual surveillance. I'll go to the other extreme. If you find that it's pancolitis but without inflammation, very well controlled, left-sided UC or CD, in that case, you can even ask for once in 5 years. So it doesn't necessarily have to be that frequent. Okay? Every 3 years for something in between, and a few of them in this category. Those with dysplasia, Naresh was referring to, previous CRC. So obviously you have resected. So that comes under the surveillance group, where it would also be possibly annual, and the type C mucosa, which they described. Okay. So this is the way one has to classify. So it's not exactly the same formula for each and every patient. There is some degree of clinical judgment you have to use. These are the guidelines which talk about what should be the societal recommendations for colorectal cancer surveillance. So ACG, AGA, ASGE, BSG, ECO, and NICE. Okay. So they all have minor variations. Essentially, the principle is the same. Those who have a high risk, you start whenever you start, but then you do it more frequently. Those which are at low risk, you can have a longer gap. This is important for our conceptual understanding, that there have been long-term studies which have showed that surveillance colonoscopy has actually helped. So there has been a reduction in CRC incidence. So you have picked up dysplasia. So you have intervened early. You have shown a reduction in mortality. And so those are the reasons from different horizontal, longitudinal studies where you have been actually able to substantiate or justify what you are recommending. Last question or statement, that in the Indian setting, surveillance colonoscopy protocol should be similar to available guidelines. Available guidelines means all the Western ones. Over coffee, I think we were discussing, Nagi and others, that actually in India, we don't really have very long series, and that's the reason why it's difficult to generate new data on the basis of which you can recommend a change. So there have been very few studies. In fact, one of them is by Dr. Saurav Kedia's group. This is the study. Bopanna is the first author. And I mean, it's a good study. Obviously, I feel proud because that's the only good Indian study. But if you look at the way it has been done, It's 1,600 patients to start with, and colonoscopy was prospectively done in 136. So obviously, these are the limitations for anybody who has worked in India. We know that it's not very easy to have a very protocol-based method. But come what may, that has been an important study. And the ultimate figures of colorectal cancer risk in that study has also been similar to what is in the West. About 30% odd cancers in people after 20 years. This is further other studies from India or Asia, very similar, nothing very different. The only good news that I wanted to share before we go for lunch is that all studies which have been looking at surveillance protocols and following up long term have actually found that there has been a slight decline in the incidence of colorectal cancer development in IBD patients, particularly ulcerative colitis. The hypothesis is that probably greater awareness leads to earlier treatment and better control of disease, because as Dr. Ajit Sood was referring to, persistent high-grade inflammation is carcinogenic, and I think that that is probably getting better controlled. And also probably picking up of early lesions, which Dr. Naresh talked about. So, but nevertheless, as of now, that's the way it is. I'm sure finished through. Thanks a lot.
Yeah, I think we request Partha to put up the slide. Yeah, this is visible. So dichromoendoscopy with targeted biopsy should be considered for surveillance of colorectal neoplasia. So the first statement, do we pass it, or any objections to this, or any additions, changes? Yeah. Yes, Chief. Second statement, okay. The first is passed. Okay. The second one, digital chromoendoscopy is an alternative to dye-based chromoendoscopy. No, because
I think we can have two. And the better
No,
is the dye-based chromoendoscopy or digital chromoendoscopy with the targeted biopsy should be considered for surveillance of colorectal neoplasia.
correct. All the guidelines do not favor digital. Dr. Naresh? Naresh, could you respond to that?
What I think the first is all right, but I think if you are using virtual colonoscopy, digital chromoendoscopy, it is used mainly for characterization, right? But if you're using high definition, you cannot use
Correct.
standard
You can
scopes
put that
and
right
use
up.
that old NBI. No.
Correct.
So I think that needs to be clarified.
Correct, correct.
So
High
we
definition
write down
white light
on the-
endoscopy, like what you put, should be specified in that case. Maybe you want to modify this, Partha, the second one. Digital chromoendoscopy is alternative to dye-based. There you can say high definition white light digital I mean, not
Should be
that cannot be
high
chromo.
definition, high definition endoscopes should be used for surveillance of cancer
That's all.
in IBD.
We will not say.
Then
that,
use
but-
next statement, you can say dye-based or virtual, digital chromoendoscopy are equal options when you're for this.
should we say equal? Because none of the guidelines approve this.
Or are good options.
Either of them can be used. And when we say high definition, then we say it should be preferred because people has done on the non-high definition with the comma endoscopy. Because if you look at the literature, they have done with the routine that is 320 plus chromo endoscopy dye based and 180, 1080 plus white light endoscopy they have done. So I think we should write down his preferred method.
Correct. So the first statement will be high definition.
Yeah, and Naresh, if you remember, all your statements were on HT white light endoscopy, not on NBI.
Yeah, we are not saying NBI. We don't
Correct.
have to put NBI.
So there chromo endoscopy doesn't come in. Digital chromo endoscopy also doesn't come in, no? You're talking about white light, high definition white light.
No. If you're using high definition white light endoscopy, in fact, the last meta-analysis with 80 thing showed that you could use only white light endoscopy without anything.
Correct.
Right? Provided you use one of those endoscope fuse where you have a much better thing. Absolutely. I think that's a great thing.
Okay.
You can add that addition of chromo endoscopy, dye-based or virtual, may help in characterization or...
Okay.
Because these are the Indian guidelines we are talking. And everybody is not using the dye base. So we are making the guidelines according to us. So we can...
So the second one you'll modify, right? That statement. Okay, he's doing it. Okay. Right. Can we go to the third statement? Newer image enhanced techniques such as confocal and autofluorescence have not yet been validated in routine practice. That's acceptable.
I think it's perfectly fine.
That's perfect. Okay, we can remove that. We can remove that. And surveillance colonoscopy should be performed after 8 years of onset of colitis. Onset of colitis, is it from the patient's symptoms or the first detection? From the time of diagnosis.
And should we write pancolitis? Pancolitis?
Okay. Should start.
No, the guidelines are that if the patient has E1 disease, then there is no need for surveillance. There is no risk of additional CRC in E1.
Only proctitis.
So we can write that this is only for E2 and E3.
Correct. Yes. You can specify that. Maybe. Yeah. Correct. Absolutely. Yeah, that's true. That is, but surveillance, the start of, Naresh.
The guidelines, I think I can quote the BSG guidelines. Clearly mention E1 disease, no need for surveillance.
Correct.
Clearly mentioned.
Confounding. Yeah, confounding.
With E1 don't have PSC.
Yeah.
Yeah, even we should not do surveillance. It is standard recommendation.
Surveillance, starting of surveillance, is it at 8 years for all? Is it a blanket recommendation? Do we follow the same as other guidelines do? Okay. Oh yeah. Okay. Fine. You said that. So that one passes, and then individuals with high risk factors, high risk features should undergo surveillance colonoscopy at 1 year interval. Can we add there moderate at 3 years and mild at 5 years? Start at 8. Sure.
And we should mention ulcerative colitis. It's not for Crohn's.
Yeah, true.
We should mention ulcerative colitis.
Colonic Crohn's. Colonic Crohn's. So I think the second statement is okay. And the final statement is in Indian setting, the surveillance colonoscopy protocol may just be the same as other guidelines say, no, the Western guidelines.
You don't require this statement.
Okay.
So we are making for the Indian scenario only.
The last one goes. Rupaji? Okay. I think with that we close the session. So please give a big round of applause to all those presenters. Thank you.